For some of you, remember that we've done this probably since, I think we started this in 2000 or so, and then we took a break with H1N1, but figured we have enough stuff going on now in Indiana and Allen County in terms of infectious diseases that it might be a nice time to get us all back together again and kind of talk about some of these issues and keep you guys up to speed, because you really are the front lines. You know, we can take the information that you guys gather in terms of diagnoses and just trends that you're seeing and, you know, things that seem a little uncertain to you and that you call us about, but at the end of the day, we can't act without that information. So it's really critical that we have a good collaboration and a good team approach here to diagnosing and preventing and treating infectious diseases in Allen County. So I think that's why, to us, this is really a good way to get together and share that information and develop that support. A lot of good things have come from this in the past. Our community-wide approach to testing for West Nile came from this. Our H1N1, I think it went as smoothly as it did in our community because of all of the work we've all been doing together. So this is very much worth our effort and on our part, and we're hopeful that it's meaningful to you all as well. I do want to first acknowledge Jennifer. She's in the room. Jennifer Miller, stand up. Jennifer, thanks for coordinating all this. Appreciate all the work you did. But Jennifer will also be your contact person. If you would like a PDF of the PowerPoints today, just sign up with Jennifer. She'll give you that as well. We're going to be talking about this poster, these two posters. There's going to be a sign-up list, and Jennifer will be coordinating that as well. So if you want to make sure that you get those sorts of materials sent to you, make sure you touch base with Jennifer to actually get on the sign-up list. Now I'd like to turn over to our hostess. I know she's around here somewhere. There she is, Terry Roberts. She's just been a great friend, not only to the community, but to the department in terms of all things community health nursing. She's the director of that program here at USF, and I tell you, if you ever need, first of all, someone to host something, this is the omelet station. She told me will be open at our break, but does a great job hosting. But she and her students, because she wasn't going to talk about herself, but I just want to brag a little bit. She and her students are just great community advocates and will help you with programs, little projects that you need that can really sort of add that extra piece to any community health nursing project that you're doing. So I encourage you to get to know Terry at the break. So Terry, you want to do a little housekeeping stuff?
Good morning, everyone, and thank you for braving the rain to get here. Welcome to the University of St. Francis, first of all, and also to let you know we do feel very privileged to be a part of the community as a university and with our nursing programs, to be active amongst our community with a lot of you that are in the room here today. So I just want to give you a few pieces of information. The omelet station is not open. But there is plenty of food, drink, water, coffee out in the hallway. Help yourselves, please, as our guests, and make yourself at home and get some food and drink. Secondly, probably the most important thing to note are the restrooms, which are down the hall here and to your right, if you need to use those facilities as well. We do have 2 intermissions built in today, so at any point, help yourself, like I said, to the food and drinks. And again, welcome. Thank you for coming.
Well, our first speaker today is Ann Applegate. She's the director of our Food and Consumer Protection Division. Summer, of course, is her very slow month when there's not much going on in the food community, right? Is it fair to say that? Really appreciate the fact that with everything going on, all the fairs and festivals and the junk food alleys, that you could take time to come and talk to us. I saw her presentation. I think you're really going to find it very informative and enjoyable. So Ann Applegate, if you could come up and talk about semi-annual update on food outbreaks.
Well, good morning. As Dr. McMahon said, my name is Ann Applegate, and I am the Director of the Food and Consumer Protection Division at the Fort Wayne-Allen County Department of Health. Our division is primarily responsible for inspecting all licensed food establishments in Allen County. So one of the major things that we face is foodborne illness outbreaks, and today we're going to look at those in a little bit more detail and give you some ideas of the causes of foodborne illness outbreaks, the costs, and also prevention. As I said, foodborne illness outbreaks are a serious public health problem, and they primarily affect the very young, the elderly, and also the immunocompromised. As I said, today we're going to discuss the cause and costs of foodborne illness outbreaks. We're also going to look at a local case study, a local foodborne illness outbreak that occurred in Allen County and affected the citizens of our community. We're also going to look at food establishment responsibilities. Per the Indiana State Food Protection Rule, there are certain regulations that are in place to prevent foodborne illnesses from occurring in licensed food establishments. So we're going to look at what the law says on that, and also some preventative measures that people can take in order to decrease the incidence of foodborne illness. Well, a foodborne illness is defined as an incident in which 2 or more people experience the same symptoms after consuming the same food. A lot of times instances of foodborne illnesses go unreported because the symptoms can be very self-limiting and they don't always require the need to seek a medical professional and have the necessary tests taken to determine the cause of illness. In most cases, people tend to recover quickly and they don't seek the time to have a test done to diagnose exactly what the cause is. And also, they don't typically report those to the local health department as well. According to the Centers of Disease Control and Prevention, poor personal hygiene, including poor hand washing, is involved in 1 out of every 4 foodborne illness outbreaks. And because most foodborne illnesses are transmitted through the fecal to oral route, 40% of foodborne illness outbreaks can be the result of poor hand washing. And it goes without saying that hand washing is the #1 thing that people can do to stop the spread of infection. Unfortunately, hand washing violations are one of the most frequently cited violations that we see in our food establishments. Food workers just aren't washing their hands often enough, or they're not washing them properly. However, improper hand washing is not the only cause of foodborne illness outbreaks. The CDC conducted a study in 2002 to 2003, and they looked at all instances of foodborne illness outbreaks. The results of the study indicated that 65% of all of those foodborne illness outbreaks were due in part to an ill food worker still working within the establishment. The pathogens that cause foodborne illness can be transmitted directly from an ill or infected food worker through the food directly to the consumer. So the greatest risk that consumers have is when a food service employee has specific symptoms of illness. Those symptoms of illness include vomiting, diarrhea, sore throat with fever, or jaundice, or if they have an infected burn or cut or wound on their hand that's infected with pus, and then they continue to work with food. There's also an increased risk of transmission if employees were recently diagnosed or if they live with someone that's been diagnosed with a foodborne illness. All of this has led to the requirement of reporting these instances to the person in charge or the management and to exclude or restrict the employee from working within the facility. Additionally, food safety experts have identified 5 foodborne pathogens, aptly named the Big 5, that contribute to foodborne illnesses because they're easily transmitted through food. These Big 5 are norovirus, salmonella, shigella, shigatoxin-producing E. coli, and also the hepatitis A virus. Well, here locally, we investigated 4 major foodborne outbreaks in 2002. 3 out of those 4 outbreaks identified norovirus as the culprit of the foodborne illness outbreak. We also had 1 E. coli outbreak that occurred at a local school. This outbreak was unique because after all of our investigations, we still could not find the smoking gun or the source of the outbreak. And I believe Nikki's going to talk about that in further detail later. As you know, the restaurant industry plays a major role in preventing foodborne illness outbreaks. In recent studies, it shows that 12.9 million people are employed in the restaurant industry in the United States. Studies also show that the average consumer eats about 4.2 meals a week outside of their home, or 218 meals a day. So that's a lot of food that people are consuming, or excuse me, a year. Excuse me, not a day. That's a different issue. That's a lot of food that's being prepared by somebody else that people are consuming. Here locally, we have over 1,800 food establishments that we're responsible for regulating. So we're going in and conducting inspections, making sure that they're following all of the rules and regulations that are set forth in the rule, and then we write up a report and give that to them and have them correct anything that they possibly can. According to the CDC, 76 million illnesses occur each year due to contaminated food. And that results in 325 hospitalizations and 5,000 deaths every year. And it's also estimated that the annual cost to the nation of foodborne illness outbreaks is $152 billion every year. This is an example of some of our cases that are reported to Allen County. But as I said before, most instances do go unreported. If, however, somebody is ill and they go to the doctor and have a stool sample submitted and it comes back positive for a reportable disease, Indiana law requires that that's reported to the local health department. Our division gets involved by going out and visiting any establishment that that person ate at during a certain time frame. Unfortunately, norovirus is not represented on this chart because it is not considered a reportable disease, although it is one of the big five. But as you can see here, you can see Salmonella, which is the green, and Campylobacter represent most of the reportable diseases in Allen County. You can see a spike in 2012 with E. coli, but again, that's most likely attributed to that outbreak that we had. This is something that the CDC put together. It's their Food Safety Progress Report, and it clearly outlines and highlights the underreporting of foodborne illnesses. The CDC estimates that for every case of Salmonella that there are 29 that go undiagnosed. And for every case of Campylobacter that are reported, there are 30 that are undiagnosed. Additionally, every case of Shiga toxin-producing E. coli has 26 undiagnosed cases that correspond with it. Again, clearly, cases of foodborne illness are underreported. So foodborne illnesses not only affect public health and the lives of the people in our community, but they also affect the restaurant industry itself. The cost of a foodborne illness for a food establishment can be measured in several ways. One can be a decrease in sales, also embarrassment or bad publicity in the media, low employee morale or low productivity, increased legal fees, and also increased insurance costs. Of course, if a foodborne illness outbreak is directly linked to a food establishment, that can have a major impact on their business. We're going to look at a local foodborne illness outbreak that occurred last year. Back in 2012, we investigated a foodborne illness outbreak that occurred. It was a norovirus outbreak at a local restaurant. The cause of the outbreak, like I said, was determined to be norovirus, most likely caused by an ill food worker who reported to work while he was ill. We were alerted by an initial call that was received from a complainant. They called in on March 28, 2012, said that a party of 8 dined at the facility, and all 8 became ill with symptoms of gastrointestinal illness. That day and several days to follow, we received more calls from parties that were unrelated to the initial complainant. So right away, we knew that we had something on our hands. We contacted the Indiana State Department of Health, and then we did an investigation the next day. What our findings showed were a lot of risk factors for foodborne illness, including improper food storage, things like raw products stored over ready-to-eat food. We also saw failure for food workers to change their gloves, maybe going from working with raw food and then working with ready-to-eat food and not changing them as required. Also, we saw a big failure to wash hands when required or wash them properly. The establishment also had an improper concentration of sanitizer. It was at a toxic level, tested way above the required 200 parts per million, and it was in the thousands. And most shocking, or most, I would say, disturbing, would be that we had a lot of food workers that were working while they were ill. So what happened to that facility? Well, because we realized that we probably had a viral outbreak on our hands, the facility closed the establishment to properly clean and disinfect, and they did that voluntarily. We also required that all ill food workers submit stool samples to us for further analysis, and we sent those down to the Indiana State Department of Health lab. Additionally, any sick patrons that we had, we asked them to voluntarily submit stool samples as well so that we could compare the findings. We also developed questionnaires, a set of questionnaires for patrons and also a set of questionnaires for employees so that we could try to find some type of link in between the two. In the end, we ended up interviewing 147 patrons who dined at this facility within a certain time frame. And out of those 147, 104 reported symptoms of illness. We collected stool samples from both ill food workers and also ill patrons, and both of those tested positive for norovirus. We only got 2 from the patrons, but both of those did test positive, and 5 out of the 6 that we took from our employees tested positive for noro. So the culprit, again, norovirus. This is some of the data that was collected from all of our surveys, and as you can see, the predominant symptoms included diarrhea, nausea, vomiting, and abdominal cramps. And the durations of those symptoms lasted from 12 to 72 hours. Majority of the people, though, convalescing after 48 hours. This chart represents just the percentage of people that are experiencing specific symptoms. 87% of people experienced diarrhea, 82 experienced nausea, 72 experienced vomiting, and 70% experienced abdominal cramps. Well, there is something that we can do to decrease the likelihood of foodborne illnesses. The Indiana State Food Protection Rule does clearly outline what the regulations are as far as reporting symptoms of illness to the person in charge. Food handlers are required to report symptoms of illness, specific symptoms including diarrhea, like I said before, vomiting, sore throat with fever, and jaundice, and they were supposed to report those to their manager. And then the manager has certain responsibilities they have to do as well. They are to exclude or restrict the employee from working around food. And they're also responsible to educate their employees. Employees aren't going to report symptoms of illness if they don't know that they're required to do that by law. And the people in charge also need to monitor people for symptoms. If they see somebody that's maybe going to the bathroom several times, they need to pull them aside and ask them what's going on to make sure that they're not ill. And they should have some type of policy in place that they are constantly educating their employees on and reminding them what their requirements are. And of course, employees have to be practicing good hand hygiene, washing their hands when appropriate, and also washing them for the correct amount of time. However, gaining compliance with these rules is definitely an uphill battle. Food establishments sometimes have the mentality of it can't happen to me, or they don't think that it's a major issue to have food handlers come into work while ill. Sometimes staffing needs tend to outweigh the need to send somebody home. They'd rather have a body in that position to get through the rush and then send them home afterwards. Additionally, paid time off in restaurants, it's just a rarity. A lot of people don't have any type of benefits, so if they don't work that shift, they don't make that money. And some people may opt to work while ill so that they can get that in their paycheck. And we also find that food establishments aren't aware of the requirements, and they don't have any type of written policy in place in order to address these issues. As I said before, one of the most important things to remember, though, is that we can prevent foodborne illness outbreaks, and we have several ways in which that we can do that. Of course, food establishments need to train their employees to understand how they occur. If they know that they can't work while ill, then they're more likely to not work. Operators are responsible for educating employees of the importance of staying home from work while ill, and they must ensure that they're practicing good hand hygiene by washing hands when necessary and prohibiting bare hand contact with any types of ready-to-eat foods. So you want to use some type of utensil like gloves or something like that in between your food and your hands. And also, as I said before, food establishments need to have some type of written policy that they're constantly educating their employees on via staff meetings or trainings so that they fully understand what their responsibilities are with regard to reporting symptoms to their manager. And by practicing all of these things, by educating our employees, by excluding ill food workers, and practicing good hand washing, we can and we will prevent instances of foodborne illness. Anybody have any questions? No? Well, thank you very much. And I'll turn it over to Mindy Waldron.
Well, thanks, Ann. That was really great. I thought there was a lot of really good information in there. And one thing that I'd like to highlight from there, I think we've seen so much of an increase in the number of dining establishments, people going out, food recalls, that one of the things I'd encourage you to take back to your providers is that while I can see where the benefit of testing, if somebody's coming in with a foodborne illness or, nausea, vomiting, diarrhea, I can see where the testing doesn't have as much benefit for the individual because it's most likely going to be self-limited, but we really can't do anything until we know there's a problem going on, and we can't do that without data. We can't go out and do some of these preventive things like interrupt the transmission of an ongoing outbreak without data. And while norovirus is not a reportable disease, if people call us and they have been to an establishment and they've been to their doctor and they've tested for norovirus, that gives us what we need, the leverage we need to go out into the facility to test. So I'm really hoping that we can start kind of changing our perspective of testing for some of these infectious diseases, not just from the individual benefit or benefit to the individual patient, but now looking more from a community protection type of situation. So just kind of keep that in mind. Our next speaker is going to talk about two really, I think, very interesting topics. Mindy Walden, our department administrator, is going to talk about our hepatitis A vaccination clinic. I think to me just was really such a great demonstration of not only public health in action, but communities working together. And she's going to talk about all that it required of not just our own amazing staff, but the community as well to put that on. But she's also done something that to me is very tedious and very difficult, and I really appreciate her doing that. If you look at the food code, For every different illness, infectious illness, there's a different requirement to be off work. Or you may have to have negative stools before. If you have this, you have to have negative stools before you can go back to work, so on and so forth. She's gone through that very tedious law and identified some, is that the right poster? Yeah, this poster, and it's really in that font, but really has helped to identify the criteria for people who are working as daycare workers, food handlers, healthcare workers, what are their requirements for them to go back to work? And she's going to talk a little bit about that. This is still a process in work, waiting for some information from the state, but I think this will be a very excellent tool for us to be able to make sure that when people who are food handlers or daycare workers go back to work, they're doing it safely. All right, Mindy?
Good morning. I see a lot of familiar faces. My name is Mindy Waldron. I'm the administrator of the Fort Wayne Allen County Department of Health. And I was asked to talk about two topics, and I asked that they be back to back, and I'll kind of merge the times. I'll try to stick within my exact 22-minute time frame. Probably spend a little bit more on this one than on the chart. And I know you can't see that, and I'll explain it. That's kind of not what we're going for. May 31st. I was getting ready to leave for a national football tournament in Ohio, heading out the door, and I received a call from Nikki in the pink over here. Raise your hand, Nikki. Takes my vacation time, Dr. McMahon's every time. Usually these happen on Friday afternoons. I get a cell phone call. Think we might have a hepatitis A and a food worker. Are you heading in? No, I'm going to Ohio, Nikki. So anyway, go into the office, we start kind of looking into it, and sure enough, yes. Long story short is to say that about 2 o'clock on that Friday, we did determine with some consultation from the State Department of Health that indeed we would need to prophylax a whole bunch of folks that attended a certain food establishment within a period of time to ensure that we got them within their window for hepatitis A. And so about 2 o'clock, we knew we needed to do that, started gathering the resources. And by 12 o'clock the next day, so 22 hours, just 22 hours, we were all set up, and I'll kind of explain how we did that, what we did, and that we piloted a new way of doing that. So in 22 hours, we're set up to prophylax both with IG and hepatitis A vaccine, all the folks, the patrons to the facility within a certain number of day window. So we were able to kind of rally a lot of resources that we already had in place, but the rate limiting step is usually the staff, whether we have enough, and we never do, so we rely on a lot of volunteers, and I'll kind of explain how we did it, and it was a very successful event for us. So some of the major steps, and I'll kind of move through these, is to obtain the vaccine and the IG, and we don't have enough of that. We don't carry IG, number one, but the vaccine in the numbers that we need, we have to get that from somewhere else, and usually the state is very instrumental in doing that for us. And so we put people on the road as soon as we knew that we needed to do it, and the state did as well, and we met in the middle of the state. They got as much vaccine from other health departments, some of their stash, and we got enough to at least start us for the weekend, and we had it back in our possession by about 7 p.m. that night. We did need to decide where we were going to hold it. The folks at Southwest Allen County Schools Transportation Building were kind enough to let us exercise our memorandum with them to try and use that site as an outdoor. And we did decide to do it as drive-through, so we wouldn't have to park folks and put them, on my first slide, you probably saw on the right side, it was a day like today. The weekend was entirely rainy and stormy, and we didn't want people lining up, having to stand outside for hours at a time in the rain. So we determined it'd be best for them to do it in the cars. Not so much best for us, but it did work out pretty well. And so we had to rally all of our sources for some of the paperwork of forms that we needed to copy in very short order. And we do have agreements with facilities to do that very quickly. We did have a lot of supplies and equipment already on hand, and I'll kind of show you some of that. The biggest thing for us was getting staff assigned and recruited, because again, this was Friday afternoon. Everybody had plans. It's it's right after Memorial Day weekend, so people were heading out of town. So we had to kind of put the kibosh on that and say we needed all hands on deck, because this would be thousands of folks within a relatively short period of time. Media, John had to dust off everything from 2006 when we did this last time and put out media communications, because the only way that folks know that they need to be vaccinated is if they hear that in some way, to say if you dined here at this time, you'll need to do X. And to do that, we needed to have very firm communications, and John worked on that for the next 3 days. That's pretty much all he did. We had to gather some volunteers, and we utilized folks from the Indiana State Department of Health, and we had volunteers that actually worked on that weekend. Our community emergency response team did primarily all of the setup, the legwork for us. We can't function at these sites without those folks. Medical Reserve Corps, we did actually have some of our nursing volunteers that we have set aside and trained for these types of things come and volunteer. And then we had nurses from some of our neighboring local health departments come, and I see Darlene in the audience. She was one of them. Raise your hand. That volunteered her weekend to also come and do that. Law enforcement, because we need all things traffic control. Food and water for the staff and volunteers, and Ann was instrumental in getting that set up for everybody. And then we always have trial and error with these, depending on the size and how we need to do it. So the setup was crucial for us. We slept like a couple hours, maybe 2, maybe none. And then we arrived to get everything set up because it's about a 3-hour setup process. You do then your clinic, which we were open 8 hours. We had to tear it all down, go back to sleep, come back and do it all over again, set it up and do it the next day. And so how we did it, just very briefly, we do have in stash, we're very lucky, H1N1, this is about the only good thing that came out of that, was that we were able to purchase things that could be used in perpetuity. So we were able to buy, we had the trailers, which are mobile clinics. They're rather small, but they are air conditioned and heated. We used them more as communications or kind of our operations centers, how we use them. And like I said, we did the vaccinations outside. So we had a lot of the things that you see there, tables and chairs, and those black boxes in the back are called pod boxes, point of dispensing, and they were like mobile nursing stations, which worked really well. And so as I said, we use these as communication centers. They're fully powered, so we were able to do news releases from them. We were able to insert or input data into CHIRP as we gave vaccinations in real time, or look people up to see if they've had the vaccine so we didn't waste. Those types of things were able to be done on site. We needed a lot of all things power to set up our tents, which are run by air, so we needed generators. That didn't work, so we were able actually to plug into actual power. And we needed water and all of the things that would keep our staff and volunteers safe while out vaccinating for a number of hours. And then we had purchased over a number of years, and we hadn't really utilized them except for a drill, 4 of these tents. And I'm going to show you, they blow up in less than a minute. Super awesome. They're actually about 20 by 20, and they protect you from the wind and the weather, and it gives us the ability to do something outside if we need to. And all things traffic, as I said, we had to define how people got to us and do that safely. All of our signage. And this is just an illustration that shows you in about 60 seconds how our tents blow up. And we have 4 of these. And one of the lessons learned for us is we need to better identify those so we can point people toward them 1 through 4. And it's very quick, and this will just kind of show you the inside of one. And you can set it up in a number of ways. So what else? We did need to be able to communicate. It was raining, so we needed a lot of things for the staff. I had talked about the forms, the clipboards, everything you need to do in the cars to do consent forms, food and water. We ended up having a very high wind weekend, so we needed to be able to secure our tents, and we found we brought some, but we needed a lot more once we got there, and so those folks were able to help us with power and securing the tents. It was rainy, but it ended up actually being more sunny than rainy, so we needed to run out and get a lot of protection for our staff that were in the tents or out in the traffic lanes. And then we always prepare for a lot of the reactions that we might have from folks that attend, so we wanted to make sure we had all those medical supplies. And then our volunteers setting up the tents. Again, they go up very quickly, but you've got to secure them and do all those things first. And that's kind of what our outlet or our site looked like. We had 3 tents. And sometimes we had 3 or 4 drive-through lanes coming to us, and they'd pull up and they'd be vaccinated in the car. We would do the consents prior and then do the vaccinations as in a drive-through fashion. And so we had a lot of lanes set up, and as I said, they would pull up, and depending on the number of folks in the car, we would send out the appropriate number of staff to do what they needed to do to the folks in the cars. And then we had a lot of communication with our law enforcement folks and keeping that kind of current. On the bottom picture, they were entering in real time, entering the data. We did have to keep our pod boxes supplied at all times. And we were always planning and kind of retooling any concern that we had traffic-wise. And what we found, that was another lesson learned, is to ensure that the site we're using doesn't have SATs, a football game, a softball game, and a dance recital. I think were the 4 major things that we were working around. So we had to completely the next day change our traffic pattern to be the other side. So that was one of the lessons learned, is kind of communicate with the other facilities in the area if you're going to bring 1,400 folks in cars. And this is kind of what it looked like. This was a slower period, but at any given time, sometimes we had well over 100 cars lined up. And we had purchased a small ATV, and it arrived that very day, the very day that we were doing the clinic, so we were lucky to be able to move some of the equipment that way. And then the folks were always stocking everything and mobilizing everything within the tents. And some of the outcomes then, this is kind of where we were heading, our goals. We vaccinated in the 2 main days, that Saturday and that Sunday, and then 5 subsequent days where we had folks that were on vacation, out of town, didn't hear about it, work in a different state, whatever, that we had to coordinate among states and other local health departments in Indiana. So all totaled, though, we did nearly 1,400 folks in about 7 days. Excuse me. And the hours work, this is enormous, it's enormously taxing on our staff who have a number of divisions that they work for, and we pull everybody in and say, this is what you're doing. And again, a lot of the money goes into the overtime paid for those folks to do that. For just our staff, well over 650 hours. For our staff during the regular day, it's still, we have a lot of phone calls, and again, as we said, we did a lot of vaccinations throughout that next week, so over 350 of those types of hours. And then we had 3, as I said, health department nurses from neighboring counties, and again, they volunteered their time, and they worked over 20 hours for us. Our CERT volunteers were there from the front to the back of these things and did anything that we asked them, running errands, just anything that we needed, especially a lot of the logistic things. And just with those folks, about 10 people, they put in over 160 hours in just the 2 days. And our MRC volunteers, 24 hours, those were actual nurses doing some vaccinations for us. And then we had some folks that we kind of asked from the State Department of Health to also volunteer, and they did, and they were runners or admin staff or whatever we needed. They were not medical folks, they were epi folks, and so, or preparedness folks, and they came in and again volunteered their weekend in shifts to assist, and they put in over 24 hours. And often, I think what we always get asked then is, well, what did that cost you? Does that balance? Did we protect the community? And of course we did, but it does come at a cost. And for us, it was about $15,000 just in those 2 days, and that's just more or less the overtime cost. We don't tend to recoup anything for your regular day's work. And we did have some site costs, some food and water and all of those things, but we were very lucky that we had most of the medical and equipment supplies, that all we had to do was go to our storage building, get it, load it up, go set it up. We did not have to purchase that. And so we replenish after these types of events to be ready for the next one. And in the state, though, they take on the lion's share of providing the vaccine for us, and most health departments when they have these types of issues, whether it's an actual outbreak or a preventative clinic. So without that, we would have had to eat that cost as well. So we're very lucky that they have funds that they're able to have this at the drop of a hat, again, less than 22 hours to get it from the bottom of the state to the northern part of the state, and did not charge us back for that. So all totaled about $45,000 just for 2 days, and for only about 1,400 people. You can then extrapolate that and imagine what that's like if there were to be something like anthrax or something larger where we needed to reach out to the entire population. We'd need all of you in this room to come out and help us do that. Just putting you on notice. And then also we had over 900 calls in just those 7 days, primarily in the first 3 days. We had all of those, but we had set up a hotline, and we had a very user-friendly hotline this time that we could track the data on and know how many called, how long those calls were, how long did they wait on hold, what message did they hear. So we were able to kind of see if that worked well. And so we did have hundreds of calls on those first 2 days, primarily, do I need to come? What does this mean? If I've had hepatitis A vaccine before, do I need it? Those kinds of questions. And so we had to staff that as well. And then after those first 2 days, you have all those calls coming into the regular lines, which still was in the hundreds for the rest of that week. And that's kind of more or less the outcomes, and I'm glad to answer any questions on that, and it kind of segues into what I want to talk about with overall communicable disease and responsibilities folks have. Any questions on our clinic? You guys are a quiet cloud. Yes, Steve?
I think it's a great response. What will you be able to provide that equipment to other counties in the district as well? What are your goals?
Did you say equipment?
Well, equipment, personnel, whatever.
Oh, I see. If they were to have something like this, his question was, will we be able to share what we have in terms of equipment and staff, perhaps, with another county that may have something similar? And we do that. And then they have done that before. This isn't our first time that we've had one of these and where they volunteered, or we called them at 10 o'clock at night and said, hey, would you give up your weekend? But we're glad to do it, too. And when Southern Indiana had the tornadoes and those types of things, we volunteer. We at least offer. Many times they don't take you up on that. As far as equipment, we have shared equipment with some other counties upon request, and it just depends on what they need and if they're doing it outside. Sometimes we do share medical supplies. That happens a lot, where between counties they'll call and say, can we share a vaccine or medical supplies, we'll get it back to you. So we all work very collaboratively, especially on these urgent things. Good question. Did you want to add something? I saw your hand. Okay. Any other questions? All right, very good. And it's kind of a segue into what Dr. Mann had requested that we look into. And I do realize you can't read it, and that wasn't the purpose of having it here. It was so you can follow just the colors and know what's on it, see it at a break. We'll put it out there, and then we'll get these to you. But what Dr. Mann had asked, because we know there's a balance between what Ann had talked about, people being off work and all of those things, but there are responsibilities within both state statutes that have to do with food and food-specific diseases, and then some general communicable diseases that may relate to people in schools or daycares or just general business. And so we thought, could we have a user-friendly tool that we could provide to folks that you don't have to read the, 200-page food code and the very long, well over 100-page communicable disease rule. So what I did was kind of marry those a bit and took the requirements for exclusion, restriction, returning to work, staying out of school, all those things, and I married them between the diseases. The reason it's a work in progress, as Dr. McMahon said, is we did find a number of discrepancies between the two laws that we're responsible for somehow enforcing when they don't match. So I did communicate with the State Department of Health, their food folks and their EPI folks, and they're working on some interim guidance until they can get the laws changed so that they're consistent. For instance, what we would find is different requirements for different diseases when those should be consistent for restriction or exclusion. And so I'm going to walk you through what this is, and all I really want you to do is pay attention to the colors and what I'm saying as far as what's on it. Then you'll want to look at it, and you can sign up to receive it once it's done. We'll send it to you electronically, and you can print it in any way that you'd like. It does print to 8.5 by 11 to legal, any size that you want, or you could do a poster size. I think most people, for me, I want to use it as a quick reference tool, and that's what it was designed for, so that if you have a question, we get a lot of those, and we assume a lot of you in practice do the same. Whether someone can return to work or what are the exclusion requirements if they have E. coli, and so that's what this is. So over a course of a few months, we tried to look through all of these, and then we all kind of had input on whether it was accurate. So on the left side, you'll see there's a yellow box and an arrow, and that just basically says, that lists the diseases or the symptoms, because sometimes it talks about an open wound in the rule, that kind of thing. That's what's on the left side. So it's in general chart form where you follow it across, and you'll see gray and kind of tan and kind of blue. And the gray kind of explains the requirements for food handlers. So if they have E. coli or one of what Ann referenced, the big 5, and then there's a few others that the food rule has in it, it will state that it must be reported. That's the first column. It'll talk about whether they have to be restricted or excluded. And then the big one is usually, when can I go back to work? When do you release me? And we wanted to make this easy as well for food operators. So we intend to give it to them as a tool as well, so that they're not having to read the rule, because we all know many don't. We find that a lot, and it's concerning, but if we can give them the help, kind of extract the main points of their responsibilities, that's the intent. And then we always have a column for other, any notes. The tan is for daycare and health workers. So there's requirements in the communicable disease rule for folks that, especially younger kids, if they have like Shigella or Salmonella, some of those things, they have to be restricted as well, and there are responsibilities for those facilities. So all we have on there is whether they must be excluded and then when they can return. And the blue is kind of for schools, some daycares, and then universities. Since we found that school was not really well defined in either of the rules, we did at this point make a clarification or a disclaimer that we mean for all schools at this time until there is some sort of a definition that's more specific to a university or something like that. But the rules are pretty specific to daycare. So what you'll see, and you'll see this at the break, if you would like to have those, we'll send it to you. I have some disclaimers and some definitions at the bottom as well, because the bigger ones are susceptible population. What does that mean? What does restrict and exclude mean? That is also referenced at the bottom. And then it is a work in progress, so we can send it out to you now with the bottom yellow disclaimer at the very bottom here that says it is not end-all be-all until we get our guidance from the state that would truly help us marry. What I did was stick with what would probably be the most restrictive. If I went through one and I found that they had different release restrictions for a different type of salmonella, I went with the most restrictive. It made the most sense. The state agreed with that. So they're working on that between their two divisions, and when we get that, we would update it if needed and then resend it out. So we probably could get it at least out to you in electronic form to utilize, just realizing that there might be some intricacies that might change over time. And I believe we have a sign-up sheet for any of our, I think we'll reference this poster later, and so you can sign up with your email, and we'll be glad to send that out to you. So any questions on the poster? Hopefully it'll be a user-friendly and a helpful tool to have in your toolbox when you need to make some references to outbreak issues.
Thanks for doing that.
Oh, you bet. You bet. Dr. Mann's idea, but I think it's really turned out to be a useful tool internally for us and hopefully externally for anyone.
Hepatitis A clinic in 2006 out at the fairgrounds, and I think some of you actually helped with that as well. And since that time, we had the experience of seeing a drive-through flu clinic done in, I think it was Hawaii, and we experimented and piloted that with a flu clinic here in Fort Wayne a few years ago. And so we decided, as Mindy said, to implement that during this hepatitis A clinic. And I just want to say that is the way to go, because one of the biggest differences we noticed was the reduced mass hysteria that happens when all these people get in a room and they're in queue and they're getting grouchy and they hate the restaurant. By the time they get there, they hate you, or they're really sick and they faint. We had to actually establish, when we had our in-house, we actually had to establish a little emergency room because we had so many people get vagal. We had one person get vagal this time. So I really think for future planning, if you're doing anything like this, having them in their car, and my God, our cars are like our little source of entertainment anymore. I think people have snack bars, radio, everything they need in there. So I think that really is the way to do it in the future, because it's not only expeditious, but it really minimizes that mass hysteria. So something to think about. The other thing with respect to the chart, which again I am so appreciative of, we're also talking about maybe when that is finalized, making that an app that you would be able to download that might make it easier for people to be able to actually use in their practice. The other thing about that, you will see, because I bet a lot of people did not realize that for some of these people to go back to work, they have to have negative cultures for some of the infections, not all, but some. Feel free, if you have unresourced people coming to you and you're making the initial diagnosis, feel free to have them follow up for those stools at our Department of Health Medical Annex, because we can do that much cheaper for them than you probably can. Saves them a bigger bill and saves you probably not collecting on a bigger bill. And Jordan, if you want to kind of stand up and kind of let people know who you are. She'd be your contact person. You can maybe talk with her at the break. And we're happy to see those folks. Again, it's a very minimal charge, just what it costs us to actually do the labs. But that's, I think, a good way for people to really follow the letter of the law, but not cost them an arm and a leg and you trying to trail after them. And that was it. Okay, well now I'm going to talk just a little bit about some of the infectious diseases that we're all thinking. Yes?
I'm sorry, just to go back to your comment about the vasovagal.
Yes.
How long did you observe somebody in their car before they were allowed to drive off?
We found that it was, we did it in the flu clinic. We observed them for 15, 20 minutes and didn't have any issues, so we didn't really observe people in their car very long at all here. I mean, just a few minutes, and then had them move ahead.
I don't personally have any problem with that, just interesting.
It was, and we really expected, in fact, I was kind of anal about that with our flu clinic, and so we would have them park over. They'd have to move forward, and it was a logistical nightmare, first of all, having people do that, but nobody had any reaction. So we didn't really feel, and the one reaction we had this time was before she was even received the shot. So, I really think it's a non-issue, again, because they're not that uptight. They're in their car listening to music, watching TV, doing their email, writing their master's thesis, whatever. They're not uptight. But that's a good question. And I think you would certainly build that in, but I can tell you from our experience, would you agree, Mindy, that it really wasn't, we didn't find it to be an issue. Now, the one thing that... Yeah, oh yes, we did observe IG. Immune globulin had a little TET, yeah. But for the routine vaccinations, nothing. What I was going to say something else. Oh, it's gone. So yeah, but it really does work well, I tell you. All right, just talk about a few things that may be coming down the road, may not. I'm tired of running around saying the birds are coming, the birds are coming. If they come, they come. I did my whole bird flu thing, H5N1. I've been on that gamut, so now we're just going to take things as they come. But I do want to talk a little bit about H7N9. I'm sure you've all heard about that. The MERS CoV update. And then, I don't know, did anyone see on the paper that the pig wrestling is back? They are going to be doing that at the fair. So I think you all need to be alert. We'll be sending a public health memo out. By the way, if you don't receive those and would like to, just let Jennifer know that as well, and she'll sign you up. We send those usually via email or fax, your preference. But we will be sending something out because they're going to have the pig wrestling, and I think we need to be aware of this H3N2 variant.
We did see them on Friday, just so you know.
Oh, did you? Okay. Are they? But they're still doing it? Yeah. H7N9 is one of the subtype of influenza viruses that's found in birds, but it doesn't normally infect humans. This all sounds like H5N1, it's just different letters and less severe. But if you've heard me talk about this before, some of this will sound familiar. It had never been identified before until, of course, where does it have its outbreak? China, where all things like this tend to come from, seriously. From March 31st through April 30th, they reported more than 126 cases of human infection with this new virus. And it does have a fairly significant mortality rate of about 20% plus. So again, it's not an insignificant influenza virus. Most of the people that they have identified thus far were actually infected after having contact with animals or in a contaminated environment. The viruses, or the birds do shed a lot of the virus in their droppings and so on and so forth, so easily can contaminate an environment. And again, once you touch these fomites or the bird or whatever, and then touch a mucous membrane, voila, you are now infected with the virus as well. As of now, 10 till 10, there's no evidence of sustained human-to-human transmission, but they really do believe that this virus is, as time goes along, developing the ability to replicate in human bodies fairly easily in respiratory tracts, and at some point may have the potential to become a pandemic virus. The symptoms, very nonspecific, like everything else you see, starts with a high fever and a cough. But these, again, and I think this is why we see such a high mortality rate, do tend to progress to those lower respiratory infections, the ARDS, a very much more severe illness, ending with septic shock and multi-system organ failure. So again, this is not an inconsequential virus. The diagnosis, there is a PCR test for this. Of course, it's only available, as you would expect, in qualified labs globally. It's getting a respiratory tract sample, nose, throat, or lung from the patient, and then, of course, they'll do the PCR. The results come pretty quickly. The rapid flu tests are not really effective with this, so you can't do a rapid swab and think you've made a diagnosis or not made one. Again, it's still very sensitive to the typical antivirals that we use, so as of now we can use Tamiflu and Relenza. They're thinking that you really, because again this tends to progress quickly into a very severe, almost a cytologic storm again, you need to do it very early on if you're going to have a response. And they're also looking at duration of therapy with the antivirals with these folks as well, because again, it has such a pronounced response. Pandemic potential, the CDC is worried about this because all influenza viruses type A really are easily transmitted, usually to people, or they at least gain that ability to do that. So they are concerned about this being able then to spread easily to person. Remember that as the third requirement of a pandemic virus. It has to be novel, which this is, never been seen before. It has to be able to spread easily from person to person, which it has not quite met yet, and cause serious disease, which it has met. So again, if it does make that ability to move easily person to person, then we do have all the requirements for a pandemic met. And again, the CDC is preparing for that, a possibility. They're looking at vaccine manufacturing, those sorts of things. But again, we all did a very good job with H1N1, but that did not have, in many cases, the potential to lead to these serious outcomes where the hospital in-house resources are really strained. Not that they weren't. I know your ERs were full, your doctor's offices, but this would be a different game than what we had with H1N1, and I think we need to be prepared for that. And when you're getting out your pandemic plans, which I think people should be now, when you get out your pandemic plans, make sure you've prepared for those kinds of difficult decisions about when you're going to end care, et cetera, so who gets in the hospital, who doesn't, et cetera, et cetera. The MERS-CoV, the Middle Eastern Respiratory Syndrome, it's caused by a coronavirus. This is very similar to the SARS virus, but it's a different virus, in fact. It was first reported in 2012, and so far all the cases have really been in the Arabian Peninsula. There have been some cases in a few other countries, but those were cases that actually started in the Arabian Peninsula. You can see there have been 90 cases so far, terribly high mortality rate, 45% or about 50% plus. Again, same thing where it tends to cause these severe respiratory syndromes. But you can see all the cases that have occurred originated in the Arabian Peninsula, and no cases in the U.S. thus far. But I do think it's important. We are sending information on this out too. We have a lot of people who work outside of this country that live here in Fort Wayne. Not unreasonable to think these people may go and do a job and come back. So we're trying to keep all our occupational health folks informed about this as well. Because again, their potential is that they can bring it back to Fort Wayne as well as they can bring it back to France. It does spread between people with close contact, so there does seem to be human-to-human transmission, and more importantly, there have been a number of clusters found in healthcare workers. So again, both getting it and giving it to others. So again, this is going to be, I think, very much like SARS. There were a lot of, after the SARS incident, there were a lot of really good articles written by nurses and doctors about SARS and what all happened in the ERs and in the hospitals. Might be worth taking a little bit of time kind of reviewing those articles. I'll try and put some on our website for people to look at because they really learned a lot with SARS, and I think this looks very much like it in terms of most of the people, or half the people infected were healthcare workers. So something to think about. Again, the symptoms with this are severe acute respiratory illness, again, with the fever, cough, shortness of breath. Half of them have died. There have been some children that have had just a mild respiratory illness, but by far, this is a very significant and serious illness we need to consider. There are tests available, again, for this as well, but again, as you would expect, only at state and global sites, national sites. There are no specific treatments for this. It's really supportive care, which always makes that very difficult. They do recognize the potential for this to spread further and cause clusters globally, including the United States, but I must say they're less worried about this than they are about H7N9. So, but again, I think this is something that all of us in healthcare, we just have to remember to take travel histories now. All right, pig wrestling. That's what it actually, I couldn't figure out how you get a pig in a half Nelson, but this is, I guess, what it kind of looks like. I think, John, was that you in there? Is that with the bandana? But anyway, pig wrestling is back. It's a variant of the H3N2 influenza virus. It's one that doesn't usually infect people. This originates in swine, and it's very different from the seasonal H3N2 viruses that we see, the human ones, and it's not incorporated in the seasonal vaccine because it's not, again, it's not a human influenza virus, it's a swine one. There were 321 people infected in the U.S. in 2011 and 2012. Of course, Indiana, we were right there at the top with 138 cases. So far, there have been 12 cases, I believe, and maybe we'll get an update from Dr. House, but there have been 12 cases so far. The vast majority of them have had contact with an infected pig, either at a health fair or some sort of agricultural, or not a health fair, sorry, a county fair, a county fair or some sort of agricultural event. It can spread from infected pigs, and the thing to remember, and this is always so hard for non-medical people to remember, in the incubation period, the virus is really actively replicating, and you don't have any symptoms. Same with pigs. They can be, in the active replication phase, very contagious, but they don't have any symptoms. So, you know, just a sneezing pig is not a sign that you shouldn't wrestle with it. You have to be worried about the healthy ones as well. So that, I think, makes it a little more difficult for people. And then, of course, we can spread it to each other through coughing, sneezing, those sorts of things. There is limited person-to-person transmission. They do think, at least at this point in time, it's less contagious than the traditional seasonal influenza A that we see. The symptoms: fever, cough, sore throat, chills, headaches, muscle aches, typical what you'd see with influenza. Children may have some diarrhea with it as well. Incubation period is about 1 to 4 days, and it can last anywhere from 2 to 7 days. Nasopharyngeal swabs, again, you don't want to use the rapid test, not very sensitive or specific. So you really want it to, if you get that history that somebody's had contact with swine and they're symptomatic, you're going to want to send that to the ISDH lab. And we'll give you this information. We'll send it again out on the memo, how you can send that down there for testing to be able to see. And again, I think this is important for public health, for us to understand really the full scope of people that may or may not be infected. So again, you're not just doing it for that individual patient to confirm a diagnosis, you're really doing it for the whole public health and population health, so we can have a better understanding of how big an issue this really is and may have to take some steps. The antivirals are both very effective for these as well. Again, with every virus, the sooner you start, the better. Some of the CDC concerns that they specifically have with this, because you think, well, it's just, it's not really infected that many people. It's not like an H7N9, but they do have some specific concerns. There are some people, especially always the immunocompromised, young and old, who can require hospitalization. There has been one death from H3N2. Not sure if it happened in Indiana, but there's been one death. This virus spreads more easily to humans from pigs than other swine influenza viruses, so again, more easily infected with some of this casual contact. And the viruses are always changing, and that's what makes them so difficult to develop vaccines for, et cetera. But it could mutate, and all of those changes, it could require that ability again to spread easily from person to person, and that's what always gives the virus the pandemic potential. That always seems to be that rate-limiting step. And then children have very little, if any, immunity to it. Some of us, I guess, must have had some secret pig wrestling in our past we've not talked about, because adults seem to have a little bit more immunity than children do. So again, that's a concern they seem to have as well. And we're going to create these posters and put them on our website if you want to download them, so that you can put that out on your triage desk, so that you can just tell the nurse if you've had a fever, a cough, and attended some agricultural thing, kind of give you guys the heads up. I definitely put a mask on them and set them in the lobby or put them in a separate area, but those will be, John's going to put that on our website, and you can just download that if you'd like. So in summary, I think the most pertinent concern we have right now, most timely concern, is the H3N2, because of all the agricultural events we have coming up in the next few months. And I just want you to raise that awareness and be confident in how to test for it. I think what I've really learned is the pandemic threat is there always. There's always something new and emerging. Viruses, to me, are the ultimate terrorists. They're always at work. So we just have to always be prepared. And I think, as untimely as our hepatitis A was, it was nice to have that opportunity again to run through everything, get out our paperwork, get through the practice, and most importantly, have the community understand that disaster medicine is different. There are no magazines or hot chocolate. We're going to make it as convenient as we can, but disaster medicine, emergency medicine like this is different than what they receive every day. And they need that experience once in a while, because initially they were grousing that they had to wait and all this stuff, and it's like, I think it's just that lack of experience with what disaster healthcare really looks like. And I really think we need to really begin asking a travel history from all people who present with fever and a cough anymore. It just needs to be a routine part of what you ask. I never realized until we opened our travel clinic how many people are really traveling on missions and work and pleasure. And they're going to places, I guess, Jennifer and I shake our heads why you go there, but they want to go there. And I think at least with our travel clinic, people are getting more prepared and preventive measures in place, but you really do need to get that travel history. And with that, I will take any questions. Mm-hmm.
We noticed with our regular flu season that PR was reporting to us that our rapid test was only about 50% accurate, and that they would test a family of 3 or 4, and only 1 out of the 4 would be positive. So we're looking at switching to PCR. Do you have any idea about this virus and how well it's picked up by the rapid test?
Not very well. None of the H7N9 and the H3N2. And in fact, there was a study done, published I think last year, that really kind of looked at these rapid tests, and for each one with each of the different vaccines, how well they performed. And I think it's great when it's positive, but I think if it's negative, I think if you're really concerned, you need to go ahead and just do the swab. But none of these aren't very effective, what I've heard. Mm-hmm.
I have to say I'm really troubled with the pig wrestling thing. My son did pig wrestling last week in Whitley County, and I had no idea, even as a nurse, that this was something that he was being put at risk for. It was $10 to sign up for each kid. There was no consent. There was no anything. The only thing I caught wind of is that they made him use hand sanitizer after they rinsed off their hands with a fire hose. So, I don't know. I guess if
And, you know, I think that's our frustration, because ISDH has been out there, and I don't know if you were going to talk about that at all, Dr. House, about, you've done a lot with trying to make the Board of Animal Health and the 4-H fairs and the county fairs and stuff really aware of this risk. We sent materials out to them. It's just really hard. I remember with West Nile, and we were at the height of that, and remember around the football games and things like that, and we were going to cancel, Dave, remember that? And we wanted, it's just really hard to change these kind of events. People really don't, they minimize the risk, and then the minute somebody does get sick, well, why didn't you tell me, you didn't tell me that this was that serious, you know? We fight that all the time, but I agree with you. I don't know, do you want to, oh, Mindy?
And maybe you're going to say this as well, but when we were looking into this on Friday, we were informed by the State Department of Health as well, and we called our local State Board of Animal Health person here to try to get something in writing to assist in communicating, and they did find out and let us know as well that the particular, and this may not allay your specific concerns, but the particular pigs that are used for these events throughout these county fairs are for that. They are not commingled animals, they're not as high risk as would be the ones that where the kids are sleeping in the barns with them, those types of things. These are meant for that, and they travel for that. So I did ask the questions, does that mean they're being tested? And they couldn't answer that, so maybe you could speak to that. But they had less risk. The State Board of Animal Health, even the letter that they gave us, it didn't preclude them from doing it because they are low risk. It just gave them those preventive measures about the hygiene issues afterwards, that kind of thing. But they weren't as worried about it as they would be of the animals that are in the barns that they are with, because those are from commingled. So it's a little less risky, not 100%. I hear you.
It's just the balance, I think, between, you know, you can't ever have it 100% safe, so I see that. I don't know, I guess for me the risk is too high.
Yeah, I agree. I think when you become aware of something, then you need to change behavior, but it's just really difficult because, you know, especially for people who've worked around these animals all their life and they think they're just not a problem. I think that's where you have the shift change, whereas we work around viruses, and, you know, the minute we hear that, we think, well, prevention. And so I think it's trying to, and that usually takes time for people to make those necessary changes. Did you want to add anything, Dr. House?
Yeah, I can add real quick, in terms of the people who have gotten H3N2B, most of them have not done any pig wrestling. It seems to be from the 4-H pigs. From what I've heard of the wrestling pigs, apparently there's a group that goes from county to county. So theoretically, those pigs may have really high immunity because they've gotten stuff in the past and maybe they're the lowest risk. I do think there's a lot of risks from having this event, from enteric illness to actual injuries, and the pigs probably don't care for it either. But in terms of our cases of H3N2B, that is not our highest risk event, even though we're really
Oh, okay, that's good to know.
advocating it being done.
Unfortunately, I'm sure it's a money issue because it was the highest attended event.
Really?
Really.
That's what we were told.
Really.
Doc-
It was not cheap, so, I don't know.
There were 60.
Culture, I guess.
Dr. Smith, do the pigs ever want to wrestle with the humans at the zoo? Do they ever make that request? Any other questions? Well, I want to take a minute before we take our break. I teased you that a little bit. I want to introduce John Silcox, our communications director, just to let you know our sexually transmitted infections are increasing again, especially chlamydia and gonorrhea. And we wanted to make it easier for people to know when to test, and most importantly, the most confusing thing is when to report potential sexual abuse for a child. So we made a poster, well, John made a poster for us, and I just want him to, this will be something that's available, and we're thinking about making that an app as well, but that's a poster that'll be available soon.
Good morning. I just want to set the record straight. I am not into pig wrestling. That's Dr. Mann. Pig boxing is my sport. Anyway, I just wanted to briefly mention, as you can see here, we do have another poster that we kind of have on display this morning, and the purpose of this was to give you an opportunity to take a look at it and let us know if it's something you'd like us to send to you as a resource. I think this came out of some research and a collaborative study we did with the Fort Wayne Medical Education Program, looking at the barriers to healthcare workers in reporting incidents of sexual abuse or neglect. And so out of that came some discussions about creating some sort of a resource tool to help people make some of those decisions. So what you're going to find on the poster is, first on the left side, is sort of an easy crib sheet to determining when you might want to test someone for sexually transmitted disease based on current guidelines. So it gives you the population that you're dealing with and then what the recommendations are. And then on the right you have information on when you might want to report instances of sexual abuse depending on the age of the participants, because as you know it can vary depending on how old the two people might be who are having sex or who have had some kind of sexual relation. So you want to make sure that you know what those rules are. And it's very difficult to memorize that information, so there's sort of a handy little table there with some instructions and guidelines to go with it. And then finally, just having that phone number so you know when to report and how to report, where to call. So it's just kind of a handy little resource. We hope it will be useful, and we are creating posters that we can actually get to you, to your practice or to your clinic if you would like some. Again, this is another thing you can sign up for that with Jennifer Miller before you leave today. We also have it already available on our website to download or print if you want to go ahead and look for it there. So hopefully it is of some use to you, and again, we're happy to try to get it to you if you'd like it. I'll defer any questions on the content to Dr. McMahon and our other staff here, but just to let you know what's available, and please see us if you would like to get copies of that. And with that, I'll break you for a short snack.
And we will hopefully continue to do that in the future to warn us that we have the potential for human infections. And then we use that data and recommend you use that data to actually community outreach, media reports, encourage people to start using mosquito protection if they weren't already doing that. Mosquito treatments, adulticiding and larviciding in response to getting positive mosquito pools in certain areas. So targeted human protection based on that environmental surveillance that we do. And we do look at equine cases. The Board of Animal Health, equine disease, West Nile virus, is reportable to the Board of Animal Health. They investigate the cases and then they tell me about those cases. And then we actually update our website with that information and we report it to the CDC. Because the animals can also serve as a sentinel for potential human diseases in an area. So that's where we had equine disease last year. And there is a equine vaccination. They do need to do it every year, but there is a vaccine available for horses and donkeys. Not forgetting the equine, so Eastern equine encephalitis. This is another arboviral disease that is out there. It does affect horses predominantly, but humans are very susceptible to it. And about 30% of the humans who come down with Eastern equine are actually going to die from it. A lot of people don't get this disease. It is a rare disease in humans, but unfortunately the ones that do get it, even if they don't have fatal outcomes, they're going to have significant problems from this particular virus. So the last time we had transmission that we were able to find of Eastern equine in Indiana was in 2010. These are positive mosquito pools, so we did have some in Adams County and up in Elkhart County. And then our horse cases, fortunately we did not have any human cases. The state of Michigan had 3, but we didn't have any. But we did have a large number of horses that came down with it, so we know it was circulating in the environment that summer. Adams County, Jay, St. Joseph, Elkhart, and LaGrange all had equine cases that year in unvaccinated horses, because there's also a EEE vaccine available for horses, but not humans. And then another disease, St. Louis encephalitis. This one has gotten very quiet. How many of you have ever heard of St. Louis encephalitis? About half of you. So there's a lot of you who've never heard of St. Louis encephalitis. This was our pre-West Nile virus arboviral disease. The last time there was a large outbreak in this country was 1975. And this was large enough of an outbreak that most of the mosquito programs that were created in the Midwest were created as a result of this program. ISDH's entomology program was created in 1975 as a response to St. Louis encephalitis. St. Louis encephalitis has not necessarily disappeared. We haven't seen it lately. We did actually have one human case in 2009. So it's something that could come back. We can't necessarily predict what's going to happen or when it's going to happen, but our surveillance program for mosquitoes also tests for St. Louis encephalitis. So hopefully we'll have some mosquito warning before we start seeing human cases. And if we do get any positive SLEs, we will let you know about that so that you can be prepared for it. It's going to have the same clinical signs as West Nile virus. Another one, lacrosse encephalitis. Who's heard of lacrosse? Because just about everybody in the room's heard of this one. Another arboviral disease that is geographically very isolated. We did have 3 cases last summer, none in Allen County, but Allen County has seen it in the past. So it's something that could come back. We did see our cases last year were a little bit south of here, and we do see probably 1 to 5 cases every year in some counties that south of here. So it definitely can't be forgotten about. This disease, it's very similar symptoms, but it predominantly affects children under the age of 16. And then dengue. Dengue is always on our radar. We have not had any local transmission of dengue here in Indiana, which is very fortunate, but we do get cases. And someone earlier mentioned mission work, and mission work is a high risk for dengue. Does anybody remember what happened in 2010? A big mission event that could have happened in 2010. Haiti. A lot of people went to Haiti that year. Haiti had a very large outbreak of dengue. 2010 was a big year. Puerto Rico had over 10,000 cases of dengue on the island. So it was a big year, but we had 14 people come back, not necessarily from Haiti. A lot of these people went to Haiti, but we had them come back from other areas of the world with Haiti, with dengue. Let's see. Oh. Well, never mind, forget that. So dengue is the most common arboviral disease transmitted worldwide. It is a human disease. It goes from humans to the mosquitoes and the mosquitoes back to humans. So that one's not necessarily an animal disease. Non-human primates are susceptible to it, but it's a human arboviral disease. And it is locally transmitted in Key West, Florida. So we know it's down there, and periodically they see cases on the Mexican border. With Mexico-Texas border. But it's something that is transmitted by mosquitoes that do exist, at least in the southern half of the country, including the southern half of Indiana. So we do worry about local transmission, which is why we ask you to investigate these cases of dengue. You know, first of all, get your good travel history so that you know potentially to look for this particular disease, and then investigate it quickly to make sure that we don't have local transmission of it occurring here, because we don't want a human arboviral disease. You think West Nile virus was bad. Just wait until we have human to mosquito to human infection. Oh, I keep doing that. All right. So that previous slide was chikungunya. I'm going to put that down.
Hit the one on the left side.
Okay, there we go. Okay, so chikungunya. This one is our next one after dengue. Who's heard of this one? Okay, yeah, now we're dropping off on the world. This chikungunya it's another human to mosquito back to human virus, and this one has long-lasting effects. People don't just get sick either and then get better or die. They have joint problems for years, decades even. People don't necessarily, I mean, they may recover, but they're going to be achy for a very, very, very long time from this. And when I say achy, I mean can't walk type joint problems. And we've never had a case of this in Indiana that we're aware of. But there have been at least 6 cases that have traveled and come back to somewhere in the country. I think South Carolina had a case last year. So on this slide you can see these are the areas of the world where we know we have local transmission of this particular virus. It is transmitted predominantly by Aedes albopictus, which is a mosquito that we have at least in the southern half of the state. I know we have it in my yard. I think we found it yesterday. It is something that could be, a traveler could acquire this disease, they could come back, become viremic, and they could transmit it in their own backyards. give it to the mosquitoes, and then we could get local transmission. We don't want that to happen. So travel history and testing are a great thing when you're talking about these arboviral diseases that could be very unusual for us. So mosquito diseases are not the only vector-borne diseases that we deal with at the State Department of Health. There are plenty of others, and these are all transmitted by ticks on the slide. Lyme, Rocky Mountain spotted fever, or what the CDC now calls spotted fever rickettsiosis, because there's other bacteria besides rickettsia that can cause similar symptoms. Ehrlichiosis, babesiosis, typhus, and tularemia. Lyme disease is becoming very prevalent in the United States. In Indiana, we do have some local transmission of Lyme disease. That's the past 4 years. We get roughly 60 to 80 cases of confirmed Lyme disease every year. So it's in Indiana, but we don't get a huge number compared to other states. It is the most common vector-borne transmitted disease in the United States, and it has very regional exposures. In fact, 95% of all cases every year come from 12 states. Is Indiana one of those 12 states? No, we're actually 19 to 20, depending on what year you're looking at. It's extremely localized, and this is the map representing where Lyme disease, the highest number of Lyme disease cases were acquired. This slide represents the residence of the individuals. During the investigations, we also ask you to tell us where they traveled to, so we know if a case was acquired locally or potentially acquired while traveling. But the 12 states are the upper northeast, or the northeastern states, and then the upper Midwest. We do have local transmission around the dunes. We do see a lot of cases from that area. So while we've had residents in most every county in the state have had at least one case, but on the case investigations, where I actually do look at that information to determine did that individual have travel history or not. And once you start taking that information out, our local transmission is occurring in the highlighted counties. It first appeared, I think the first case was up here in Jasper County. The majority of our cases are right along the dunes up here on Lake Michigan. But we've had locally acquired cases in these counties here and these counties down here. So for some odd reason, it's moving south instead of east. But that's not to say it won't. We have Ixodes scapularis, the tick that transmits Lyme disease, in almost every county of the state. So it is possible that it could move, but this is the path that we have seen Lyme disease move so far. And this slide, I updated it last summer. I'll probably update it again at the end of this summer. There are CDC requirements for whether you're an endemic county or not, but those are currently the endemic counties, and that matters when we're talking about CDC case definition and what you call your case and how you diagnose it, whether it's confirmed, probable, suspect, or not a case. So Rocky Mountain spotted fever, this is one of the oldest vector-borne diseases we know about. It's been around for a while. It's sort of misnamed Rocky Mountain, as in maybe that's where they first diagnosed it, but that is not where the majority of the cases occur. The majority of the cases do occur in the Appalachian Mountains, so not the Rocky Mountains, oddly enough. But we do have it in southern Indiana, and we do have cases every year. This one's a little challenging to diagnose because it's a antibody test. So the antibody test, we don't necessarily know, looking at it, is were they currently infected this summer, were they infected last summer? So we have to call a lot of cases probable. Now that's CDC definition. That does not change how you diagnose or treat your own patients. It just changes the number that we report to the CDC at the end of the year. So if you have a suspected case, treat it. But treat it before testing, because Rocky Mountain spotted fever can be fatal for individuals. But last year we did have roughly 30 cases, 2 that were confirmed through serological testing and titer increases, but then 28 that essentially only had one snapshot picture right when they first got sick, but then they didn't come back and do a convalescent test. That's why we recommend convalescent testing, is so that we know for sure was that recently acquired, and is that what's making them sick. The big one on the horizon here is Ehrlichia. How many have heard of Ehrlichia? Not nearly enough of you have heard of Ehrlichia. Ehrlichia is becoming a huge problem in southern Indiana. Last year we had 18 confirmed cases and 17 probable. This is a big number for a tick-borne disease. So it's a bacteria. What's called ehrlichiosis is a disease category. It's actually caused by multiple types of bacteria that are either in the Ehrlichia or Anaplasma category. So that's the name of the bacteria, but they all cause similar symptoms. And the symptoms are almost identical to Rocky Mountain spotted fever. A smaller percentage of these patients are going to get a rash. Only I think about 20% will get the rash, so 80% aren't going to have a rash. But even your Rocky Mountain spotted fever cases don't all get the rash. So it's, that's not a hallmark sign of either disease particularly. So ehrlichiosis looks like Rocky Mountain spotted fever. It's transmitted by ticks. So if you have a person who presents with characteristic signs of Rocky Mountain spotted fever, test them for both Rocky Mountain spotted fever and Ehrlichia, because we're seeing a lot more transmission of Ehrlichia in the state. It's in the southern third of the state. So travel history, if they've traveled down to southern Indiana, if they had tick exposures, this could be a cause of their symptoms, and it can also be fatal. The next couple of years, I think you would continue to see this go up. We more than doubled our case number last year, so it is becoming more prevalent. And then Babesia. So Babesia is a tick-transmitted disease, but it's a little different. It's a parasite, not a bacteria. Why is that important? Throw it out there.
How do you acquire it?
Actually, no. But it is tick transmitted. Good idea, though. Why would you?
Just the way you would treat it.
Right, exactly. So doxycycline for this particular one is going to do nothing unless they have like a co-infection with another bacteria. So it's a parasite, so it needs an antiparasitic treatment. It does infect the red blood cells, just like malaria does, so some of the symptoms could be very similar to malaria. So if you have an individual that's presenting with malaria-like symptoms and you see something on your blood smear and they've not had any foreign travel, think Babesia. So those blood smears are going to be very important to look for that. And it is also transmitted by the black-legged tick, which is Ixodes scapularis, which is your same tick that transmits Lyme disease. Most people who acquire this are going to be completely and 100% asymptomatic. It's not going to have any symptoms. Now, this is going to cause a problem in that if they acquire it, if they have it in their blood and they're not having any symptoms, it can be transmitted through blood donation. There is not currently a blood test available for donors. So they have seen some cases of blood transfusion transmitted in the Northeast where this is a more prevalent disease. It's very rare here in Indiana, but it is something that is concerning, and they're aware of this, and they're trying to develop a blood test for donors to prevent future transmission. But if you get a case of Babesia, that's another great question. Have you donated blood, because we need to have that blood pulled from the supply, or did you receive blood donation? Those are really important questions to ask if you get a case of Babesia. For people who do get sick, people who have a blood transfusion are much more likely to get sick from this than someone who acquires it from a tick bite. And it can cause hemolytic anemia because it does infect the red blood cells. It can also be transmitted congenitally. So a pregnant woman that acquires this, she may be completely asymptomatic from it, but then her infant will, these infants are very susceptible when they're born, and usually within the first 5 days, they may become jaundiced and have some hemolytic problems. So that might be something to think about if you have an individual that either received a blood transfusion when they were pregnant or potentially did a lot of recreational outdoor activities with tick exposures. Babesia in the newborn could be a problem. So it is not very prevalent in Indiana. We've never had a confirmed case. So we've not had a case that was diagnosed on a blood smear. We've had 3 probables and 1 suspect case, and that just has to do with the CDC case definition. If you're not familiar with those and you want to know more, I can direct you to that website also about why we name them this. The first 3 had travel history to the upper Midwest, I believe. So we don't necessarily think, even if they did have it for sure, we don't necessarily think they acquired it here. This case, this one looks like it most likely is a case. It was diagnosed on antibody titers. The CDC did look at that, and they are pretty confident it's a case. We can't call it confirmed based on the case definition, but we're pretty sure it's a case. And this individual did not travel to high-risk areas, did not receive a blood transfusion. And any guesses as to what district the patient was from? Not yours. No, don't worry. This individual had a lot of travel in the southern part of the state, districts 8 and 10. And this was unusual for me. I expected Babesia to take the exact same route that Lyme disease took, entering the state at the dunes and then moving south, and it didn't. This individual had never traveled to a high-risk area for Babesia. Did have extremely high-risk tick exposure. We're talking 100 tick bites every weekend for an entire summer. So the individual was definitely at high risk for all tick-borne diseases. So also another good history question. Find out what your patient does. What do they do recreationally? What do they do for work?
What did that person do?
Recreational activities. They were out in the brush all the time. And that was one of the first things she said, I might have a tick-borne disease. I don't know what it is, but I do get a lot of exposure to ticks. So that it's very good historical information to find out what they're exposed to regularly. I know you guys are like, ticks, 100 a weekend. So, this is something to keep on the radar. That individual was sick for months before it got diagnosed because nobody really expected this particular pathogen. They were testing for all of the other tick-bornes because we have all of those other tick-bornes. But this one's sort of, it's new. It's novel, Healy's here in Indiana, so it's something to keep on your radar that could be causing problems in your patients. Typhus, we still have typhus, Rickettsia typhi. We occasionally get a case of this, 1 every 2 to 3 years or so. It's still out there. We don't see a lot of it, but it's also something to think about. And then tularemia. I think we have a lot more tularemia out there than gets diagnosed. It is transmitted in multiple ways. There's about 6 different ways this can be transmitted. Since this is a vector-borne talk, that's what I'm going to talk about. Ticks and deer fly can transmit this particular bacteria. The symptoms are also going to be different depending on how it entered the body. So tick bites are predominantly going to appear as ulceroglandular. So wherever the tick bite was, they'll get a sore, and then it's probably going to be a non-healing lesion, and then regional lymphadenopathy closest to wherever the tick bite was. So tularemia, it doesn't get a lot of press lately unless it has to do with bioterrorism agents, but it is still a naturally acquired pathogen. It's out there, and it's still fairly prevalent. In the U.S., somewhere, there's between 100 to 125 cases every single year. Here in Indiana, we don't get that many by any means, but we do get it, and we see it predominantly in the southern half of the state, but that doesn't mean you won't get a case up here. The reports are going down. This is historically known as rabbit fever. Rabbits are susceptible to it. Rabbit hunters are susceptible to it. People who get out there messing with rabbits get it. But it's acquired in other means. But we've had a huge decrease just because of human activity. It's still in the environment. Animals still get it. But we don't have as many human cases as we used to see. So far in 2013, we've had 2 confirmed and 2 probable cases of tularemia, all naturally acquired. And then over the past decade, we've had 12 confirmed human cases. So it's still out there. If you see a case of it, it doesn't mean it's a bioterrorism agent, but they do need antibiotic treatment rather quickly. And we need to know immediately so that we can do our investigations to determine Was it naturally acquired, or do we have a potential threat on the horizon that we need to worry about? And then I just wanted to throw in a little bit about laboratory reports, particularly for tick-borne diseases. They can actually get very complicated. When you're talking about antibody tests that are looking for titers, there could be false positives, or it could be that they were infected previously in another summer, and that's not what's making them sick this year. Laboratory reports are reportable to the State Department of Health, so we get just tons and tons of laboratory reports. In addition to your reports, your communicable disease reports based on symptoms, we're getting the lab reports. A lot of them, like almost half, don't actually pan out to be cases. It's just the nature of how testing is done. Testing, it's probably one of the best tools that we have. Clinical symptoms, history of exposure, and testing are what we have to work with. But just because it says positive doesn't mean that that is actually what they have, and that's important to know. Lab tests are not always great. The laboratories do the best they can to create tests, but they cannot be both 100% specific and 100% sensitive. It's just not possible. With that, you end up seeing some problems with testing. There can be high false positives so that you don't miss a case. Testing is not always indicated by clinical signs, which is going to increase your number of false positives. Different laboratories use different testing methods, so what one laboratory says might mean something different than what another lab says. They may have the exact same blood and they just test it in different ways and then report it out in different ways. Sometimes they're very hard to read and understand. Whenever I get a new lab or a new test from an old lab, a lot of times I have to call, and I have to have somebody at the laboratory walk me through what they're trying to tell me, because they're not necessarily intuitive. So sometimes you get these strange things. Recently, they started reporting Lyme disease as progressive Lyme disease, and then they won't give me a titer or a positive or negative, and I'm like, well, what does that mean? And then they change, like Lyme disease, for some odd reason, the labs change every year in how they report it. So it's a lot of work to keep up with how to read and understand these. Different reporting styles. Not all laboratories and laboratory testing is approved by the FDA. And that might be concerning, but that's essentially how all lab tests start out in one lab somewhere. They have a need. They figure out how to do a test. They work with other laboratories, and then they start working with the FDA to get their clinical trials and testing methods. So a lot of times hospitals and facilities have what they call in-house tests, which don't have to be approved by the FDA because they're supposed to be used in-house by their own physicians diagnosing something that they think is becoming prevalent in their area. So that's important, if you are doing a send-out test, to check if that is an FDA-approved test to be done. And the criteria for positives from these laboratories is not always the same between labs. What's positive at one lab might be negative at another lab. So depending on where you send it to, so you got it, one lab report, same blood sample, same symptoms, same person. One lab says it's positive, one lab says it's negative. So which is it? And there are labs that have different testing criteria. So that's important to look at when you're testing a patient for a disease. This is a slide from the CDC that just shows how testing, sort of how it works. Now this is the exact same test. This is an example slide of why you should only test for individuals that have clinical symptoms of a specific disease. Just throwing the book at them, testing for everything in the world isn't going to necessarily be the best thing to do, because that's going to increase your rate of false positives. So this is the exact same test, and this is an imaginary test because it has 98% sensitivity and specificity, which is practically impossible. This is like the best test on the market, and it doesn't actually exist. So utilizing the best test on the market, so if the disease is common, you test 100 people where there are a lot of people that have the disease, you're still going to get 3% false positive rate using a 98% test. That's really good. There's still one person that was misdiagnosed based on this laboratory test, but that's great. So the exact same test is used in a population where the disease is rare and you completely change your rates. So you test 100 people in a community where the disease is very rare, and you end up with 2 people with false positives. So you have twice as many false positives as you do true positives. And that's just the nature of testing, and that's what we have to work with. So, sorry about that. It's just your test, you just can't 100% rely on. You still need to use them. They're still very good, and they help give you an idea based on your clinical signs and your history, but don't rely 100% solely on those tests. And Lyme disease is becoming more of a topic, both here in Indiana and other parts of the country. And so I've created, this is an algorithm to help the local health departments. This is to help you understand what is going to get diagnosed by the CDC as a case or not a case or a probable case. So this is a diagram. I do have copies for those of you who investigate cases of a disease or you want to see how we work through. This is an Indiana-only document. This is specific to our situation here. And it just talks about, it's based on your communicable disease reports. So a physician reports a case, and then you look, well, where did they, here in Allen County is not an endemic county, but did they travel to an endemic county? That's important. What are their symptoms? Do they have erythema migrans? Do they have arthritis? And then you can just work your way through that. And, you could have all the symptoms if they're not in an endemic county and they only had an EIA or an IFA test, it's not going to be called a case. The CDC wants them to have double testing with either an EIA and an IFA and a Western blot test, all of that to confirm a case. So that's just some of the things we work with, and I do have that chart available if anybody wants a copy of it. And then the things the CDC is looking for us to be able to call it a case. Case definitions are standardized. We use the exact same case definition as Connecticut, Hawaii, California. We're all using the same case definition throughout the country so that we can have an idea of physicians that you can diagnose in your practice, but it may not meet case definition, and we do that so that we know we have some standardization between states of what is called a case and what is not called a case. So that's my information.
So please welcome him to talk to us about the similarities and differences in infectious diseases.
Thank you, guys. Can everyone hear me okay? Yeah. All right, perfect. Well, this started out with a meeting where I was asking about what we can do to control infectious diseases from people to our primates, because we give them things like enrichment items and toys and things like that. We're looking at ways that we can prevent some of these infectious diseases from reaching them. And it became surprising to a lot of people that we share so many diseases, and also that some of the diseases we share present in different ways. And so I was asked to kind of give a little bit of an overview, and this is like saying, let's talk about human medicine and all the diseases that people can get, but because primates are so similar that most of the things that we get as people, primates can get as well. So I'm going to start with a little bit of taxonomy, and I'll go through this really quickly because I think it's important. In zoo medicine, we see a lot of diseases that fall along taxonomic lines as far as which species they affect and don't affect. So primates, the order is divided into 2 suborders. The Strepsirrhini we call prosimians. These are kind of the lemur types. And then everything else is in the Haplorhini. These are some of those prosimian orders. Tarsiers are one that kind of falls off to the side. So lots of cute pictures of primates coming up. Some of the prosimians we have include these dwarf and mouse lemurs, the traditional lemurs from Madagascar, sportive lemurs, and some things like shafakos and indries. Eyes, this crazy looking thing from Madagascar, is a primate also. Lorises, bush babies or gallegos, and tarsiers. So even though a lot of these things aren't really recognized as primates, they are primates, and kind of in one of those early branching groups. So like I said, the tarsiers kind of branch off earlier, and then we have the simiiformes, or sometimes referred to as simians, or the monkeys, and kind of everything else. Those guys are divided up again. The platyrhines are the New World primates, so everything in Central and South America. We don't have any native North American primates other than people. The Catarrhini are all the Old World monkeys and apes kind of grouped together, and they're all separated there. So New World primates, we have the cute little marmosets and tamarins, little guys from Central and South America, capuchin monkeys, squirrel monkeys, owl monkeys, saki monkeys, and spider monkeys. When you get to the Old World primates, this is one of the largest groups, the Cercopithecidae, and there's over 73 species in this family alone. But these are the macaques, the guanons, the mandrills, then also the leaf-eating monkeys like colobus and langurs. Getting a little closer to people, we have the Hylobatidae. Those are gibbons, or also sometimes called lesser apes. And then in the family Hominidae, those are great apes, which include gorillas, chimps, bonobos, orangutans, and people. The reason this is important is because the diseases that primates get are going to be grouped according to these families. So people are down here in the ape group, and we find that just about all of the diseases that people get are great apes also get. When you start branching off farther away the taxonomic tree, we see fewer and fewer opportunities or diseases that cross over those taxonomic lines. Also, the disease, the way it manifests, becomes a little different the farther away you get from people. So herpes viruses are a great example of that we'll go into in a minute. So I want to talk a little bit about how zoos handle primates, because most of us kind of see them from the visitor's side, and you know, they're cute and funny and they're entertaining to watch, but there's a serious side to that, and that they do carry a lot of our same diseases and a lot of zoonotic diseases that we have to be concerned about. In the zoo world, we do not consider primates as pets. Don't condone that practice. You know, the dressing them up and treating them like children. I mean, there's just too many safety issues, zoonotic disease issues associated with that. I don't condone monkey wrestling in case the pig thing comes out. So, which is what having a primate as a pet turns out to be. They also behaviorally are really messed up monkeys. So, you know, they never, even if they do, you know, leave that home, usually they don't get along with other monkeys, and they don't get along with other people, and they become very aggressive, and many times people will file down their canines so that they can't bite them and cause traumatic injuries to the people. So a lot of bad things go on in the pet monkey industry. Service monkeys, there's a little bit of a trend towards that. You know, in some ways, I think people kind of consider that just a way for people to have a pet monkey and make it somewhat official, but I don't think there's necessarily a place for service monkeys out there either. But a lot of people would work in sanctuaries and private zoos, and one thing I'd like to point out is that the legal issues around primates are very few and far between. Most of the time there's city ordinances or maybe a county ordinance in large municipalities, but most states and certainly federally there are a lot of laws regarding the ownership of primates or exposure to primates or how they're handled. So it's generally up to the institution or the county or city level. Like I said, the zoonoses is a big concern for us. We have entire, protocols and policies for when we handle primates or go into their areas or clean their cages, and what PPE is required and who has to be trained, and we have specific procedures on how we're obtaining blood samples. We do TB testing of all of our staff that enter any of our primate areas. We also recommend vaccinations for certain diseases. One challenge that we have with labs is finding ones that will be willing to accept primate samples due to the concern of the zoonotic diseases. But when you think about it, there's one primate that shares 100% of our diseases, and that's people. So if you've got the practices and protocols in place to prevent acquiring diseases from your human samples, chances are you're not going to acquire them from your primate samples either. So it's kind of one of those fear of the unknown type of things. Any new animal into the collection, not just primates, but everything at the zoo, gets quarantined in a separate building for a minimum of 30 days. During that time, they get a routine physical. They get a lot of parasite and other fecal exam screenings. They usually would do survey radiographs, ultrasounds, update them on their vaccinations, TB testing. We do a lot of viral serologies and things, screening for certain infectious diseases. And so if they don't have a known medical history, so most animals in zoos are transferred from zoo to zoo. They're not coming out of the wild. They're not coming from unknown sources. They're able to be tracked back multiple generations through the record-keeping system that we utilize. And so we generally are going to know their medical history. But if for some reason we do have an animal with an unknown medical history, we'll quarantine that animal for a minimum of 90 days. Our preventative medicine consists of an annual exam, and some of you guys might be jealous of this, but we do get to sedate and anesthetize all our patients before we have to handle them and do their exams, so it makes it a lot easier and safer for us. But we do that either through training. Some of our animals will actually present shoulders, and we can inject the induction drugs that way, or we do have squeeze cages where we can hand inject them for their anesthesias. But while they're down, like I said, we use radiographs as a screening tool. Most of my patients can't tell me that they're feeling something funny in their belly or something's going on there. So we actually utilize that as a screening tool to look for problems. We're the dentist too, so we do a thorough dental exam. They generally don't tell us when a tooth hurts. We find really nasty abscess teeth in there sometimes, and no clinical signs associated with it whatsoever. CBC and Chem, no matter what, anytime we get our hands on one of these guys, we're going to do that. Lots of viral serologies and also some parasite ones as well, like toxo and things like that. This is the way that we know what's in our population. And just like Dr. House said, using it in this manner, we do get a lot of false positives that we're going to have to deal with and sort out. But it is one of our only ways for these animals to be able to tell what's in these small populations. Fecal cultures looking for enteric pathogens, also parasite screens and TB testing. All this is done essentially annually for all of our primates, so we're getting our hands on them that often. Briefing on vaccinations, the ones that we use routinely in all primates is generally rabies and tetanus. As you get closer to the apes, we'll use more and more of the human vaccine protocols, to the point where if we're hand-rearing a great ape like an orangutan and it's getting a lot of human exposure, we will follow the CDC guidelines, recommendations for children for that particular infant. We'll use those human vaccines on them because they are considered to be at a higher exposure level than if they were being reared by their parents. So. All of these are off-label vaccines. They don't make monkey vaccines. So they're either human vaccines or we're using others borrowed from other aspects of veterinary medicine, like a large animal or small animal stuff, so dog, cat, horse vaccines. TB testing is something we do annually for all of our primates, but we do it a little differently. There's some differences here. We generally use the tuberculin syringe, the small gauge needle, 0.1 mils of mammalian old tuberculin. This is made just for primate testing. We use the upper eyelid because yes, I see some people making funny faces there, but this is a way that we can read that test without having to anesthetize that monkey again several days later. And we can actually see it. We will go and visualize that at 24, 48, and 72 hours to try to differentiate some of those flash reactions from a true positive. There are reports of using other places like abdomens or forearms, but again, you generally have to palpate those, whereas if there's any swelling in the eyelid, you're going to see it. There is a grading scale, and I have no idea how different or similar this is to what you guys do in people, but there are 0 through 5. Ignore the red pigment on the monkey on the top, because that's just normal pigment for him. So ignore that. It's not erythema. Instead, look at the swollen eyelid there. That's what we consider a grade 4. There's obvious swelling with drooping of eyelid. This is a grade 5 with marked swelling and necrosis, so both of those would be positives. Yes, question? I will get to that in just a second. So, ancillary TB diagnostics. So nice segue. If we use the TST as a screening test, just as you guys would. We can do some comparative testing in the animal world. If a cow or goat were positive on a TST, we do a comparative skin test where we inject the PPD bovis and PPD avium and compare the reaction between those two to decide if it's one mycobacterium or the other. That's not as well worked out with primates, so we can still do it, but we don't usually do that alone. There's nice little charts for the cattle and goats that they can plot them and tell if it's a suspect or positive. We'll do a gastric lavage or BAL to do acid fast, cytology, PCR, and culture. The reason the gastric lavage is because a lot of our monkeys are really small, and to be able to get a BAL is a little more risk involved there. So the theory is any sort of mycobacterial agents they're going to have, they're going to be swallowing that mucus and it's going to be in their stomach, especially a fasted animal. Since they're anesthetized, they're going to have an empty stomach just with nothing but mucus. So we're able to retrieve some of that and get samples that way. This is a Saki monkey that is under my care now that's positive for Mycobacterium zulgi infection. She's got a lymphadenopathy and a hepatitis and some other issues. So one of those atypical mycobacteria that's rarely encountered but was found through our testing protocols. The gamma interferon testing that I think you're asking about is available. It's not as readily available for primates as it is for some other species, but we run into some volume issues for some of the smaller guys as far as how much blood they need. Is everyone familiar with gamma interferon testing? I don't want to go into detail about things you guys already know about. There's also some ELISA serologies, the ChemBioStat pack. It's been validated for some species, so macaques it works for, but they're finding that in other primate species, particularly great apes, it does not work. So at this point, we don't use it for primates at all. Very muddy picture that this can paint when you get a skin test positive and you don't have any radiographic lesions and things like that. And can make it challenging. So to diagnose this as a true positive, or is this an atypical, or is this something else going on? So we kind of use all these things together to try to make our best judgment, and we usually get other smart people involved to help us figure that out as well. Fecal diagnostics we run at least twice a year. We're looking for parasites in our primates. Doing fresh, direct, and centrifugation techniques. We'll also do the fecal culture for enteric pathogens, looking for Salmonella, Campylobacter, Shigella, Yersinia, that sort of thing. We also, in-house at the zoo, we run the Giardia and Crypto ELISAs. We find that's a much more sensitive screening tool for some of these things. We are seeing some subclinical Giardias in our lemur group, and we're wondering, because of how far separate they are from people, if some of that Giardia might be something other than the typical Giardia lamblia, just based on how it's responding to treatments and how we're seeing it long term. So if anyone's ever interested in Giardia research, this may be one where we're dealing with something a little different. We discover new species of parasites and viruses and bacteria in zoo medicine all the time because no one's ever looked. I can think of a couple novel viruses that we found just at the Fort Wayne Children's Zoo alone that are completely new to science. So it's just a matter of looking for these things. Having said that, we do a great job of protecting all our visitors from these things. So. Bacterial diseases, like I said, tuberculosis. We do see the M. tuberculosis, but we also see a lot of other mycobacterium. M. bovis can cause similar lesions in people, in primates. And we also will get the atypicals as well, particularly in immunocompromised individuals, very similar probably to what you guys see. We don't get those mineralized granulomas in the lungs, though, in our primates. We're more likely to see a mediastinal or hilar lymphadenopathy on those chest films. So we still run the chest films, but for slightly different purposes. More of a problem in our old world monkeys than in our new world monkeys. So the prosimians, the new world guys, we don't see this as much of a problem, even though we still include them in our regular testing. In treatment, so they do a great job of keeping enteric pathogens and things like that going strong in their groups. We see all the same things that you'd see in people. We see them as subclinical carriers. We know that only because we're screening actively for them. We don't treat unless they're showing clinical signs, so we don't want to set up resistant strains and things like that. But we would initiate, additional PPE and isolation for animals that are positive. Tetanus, same as people. Same thing for listeria. Part of this is from a presentation I gave to exotic animal practitioners on some of the diseases, infectious diseases we see in primates. But I have had one case of a listeria abortion in a monkey at the zoo, probably acquired just environmentally from the soil or possibly from food. It's kind of hard to trace that back when you're dealing with a single case, but we're able to culture the listeria from the aborted fetus. Streptococcus, a couple interesting ones. We have seen it in other zoos, the strep pneumoniae causing meningitis and arthritis and things. The strep zooepidemicus is more of a problem with horses, and incidentally, this occurred with some of these little marmosets and tamarins that were sharing an enclosure with a carnivore that was receiving a horse meat-based diet, raw horse meat. So it was exposed that way to this sort of horse pathogen, and caused the lymphadenitis and splenitis. Viruses, the one big one that everyone gets scared about when we talk about primates is herpes B. If you're using the more current viral nomenclature, it would be macacine herpes virus 1. The macaque is the host for these. This is their cold sore virus, causes little vesicles or mucocutaneous junctions and things like that. Generally doesn't cause a problem for them. They're subclinical most of the time. But you get that virus into a person and it's almost always going to be fatal from an encephalitis. And we'll see that with a lot of our herpes viruses, and I'll show you on the next slide. But this is something where in institutions that house macaques generally are wearing Tyvek suits and face shields and goggles and face masks anytime they're interacting with those animals or cleaning those enclosures because of herpes B. That's not something anyone wants. We don't have any macaques at our zoo, but they are a commonly kept species. They're used a lot in lab situations, but and you'll sometimes see them as pets, despite all that. There are still people that have macaques as pets, even here in Indiana, so the exposure potential is there. So all of our herpes viruses, these gamma herpes viruses, kind of act in a similar fashion in that they've evolved to infect the host species. And in that host species, they don't generally cause many problems, usually small cold sores or things like that. You get it into a closely related species that's close enough to be infected, the virus kind of goes haywire and causes pretty severe disease, usually meningoencephalitis and things like that. So our squirrel monkey herpes virus is lethal to callitrichids, marmosets, and tamarins. So we have to be careful, about what primates we're mixing. The spider monkey one, same thing, and human herpes simplex 1 and 2. fatal encephalitis in a lot of our primates. So as part of our primate protocols, anyone with active cold sores isn't allowed to work with primates or prepare their food because it can have pretty fatal consequences to the animals in our collections. Primate retroviruses are probably the second big one that folks worry about. That's because HIV and the human T-cell lymphotrophic viruses show direct lineage from these primate ones. And even though these aren't known to be directly, with one exception, aren't known to be directly zoonotic, mutations can occur again and certainly could cross over. So these are the ones we screen heavily for. Foamy virus is a little different. That is not known to cause clinical signs in people or in primates, but has been shown to regularly cross over to occupational positions that are working with primates, so zookeepers and lab workers and things like that. So it's one of those that hopefully doesn't we don't learn about 20 years from now is working in conjunction with something else to cause some major disease. But it's probably only been known about for the last 25 or 30 years where people have really started looking at that. We do have foamy virus positive primates at the zoo. Just like with the human retroviruses, these are going to cause immunosuppression. They cause lymphoproliferative neoplasias, B-cell lymphomas, T-cell lymphomas, leukemias, things like that they're affiliated with. So, kind of like the enteric ones, I kind of grouped all these into one slide, but they're pretty significant in that we see respiratory disease in our captive primates a lot. It's one of the things we particularly are concerned about with our apes. We will give our orangutans, for example, seasonal flu vaccines. We have a female with chronic respiratory disease that basically she's like a cystic fibrosis type patient with bronchiectasis and some other changes there. So we don't want her getting some of these viral things, so we take extra precautions with her. But there have been outbreaks and mortalities associated with respiratory syncytial viruses and metapneumoviruses and things like that, mainly because they'll sometimes combine with other pathogens. But like I said before, these guys house together. They share their pathogens readily with one another, and it'll just go right through an entire primate collection. Measles is generally a problem acquired from people and has the same issues. Encephalomyocarditis virus is not something we have to worry about here necessarily, but it's a cardiovirus, a type of picornavirus that's spread by rodents, primarily in the Gulf states, but does affect primates, causes some myocarditis lesions. Lymphocytic choriomeningitis virus is another mouse-borne one. This one was associated with callitrichids that were actually or marmosets that were being fed pinky mice as part of their protein portion of their diet, and so we're getting this virus as from their food items. But they can also be exposed to rodents in the building if there's an issue with rodent control. So. Hepatitis viruses is another one of those that's similar but different. We've already heard a little bit about hepatitis A today, and primates certainly get that as well, and we do screen them regularly for it. Hepatitis B is a little different. These hepatinoviruses, although the human hepatinovirus can cross over into a lot of the primates, there are also other primate hepatinoviruses, particularly in Javan gibbons and in some of our great apes, that we don't really know what they do in people because not a lot's been worked on with these viruses. But we recommend to our staff working with Javan gibbons, for example, that they be hepatitis B vaccinated. Certainly the testing crosses over, the serologic testing crosses over with the different viruses, and we're going to assume potentially that the vaccine would probably do as well. The problem is you're never going to get, it's one of the most endangered primates in the world. We're one of the only zoos with them in North America. The other places are in Europe and Australia. You're never going to find animals that you can do challenge studies for. We never really learn, what vaccines are working and which aren't. So it's another opportunity for research. Anyone likes hepatinoviruses, being able to differentiate which hepatinovirus an animal has been exposed to based on that serology would be very helpful. Because we just can't tell. We can't differentiate these primate hepatinoviruses from the human ones. The other hepatitis viruses are less commonly reported in primates. Rabies is another one. Causes just as many problems in primates as it would in people, so we do vaccinate them because no matter how many times you tell them don't go play with the bat, they're still going to go and play with it and get bitten, and and they're not going to tell you they got bitten. So we vaccinate all of our primates using. We actually use the veterinary vaccines for that to provide their protection. But if those primates were to bite someone, the state would not recognize them as vaccinated because it is all off-label, and we don't know the true efficacy of those vaccines. So we're doing it for their own protection. I'll go really quickly through parasites because I know we're running behind time, but strongyloides is something we see very commonly in these guys. Slightly different species depending on which group of primates we're talking about. These are ones that they can auto-reinfect themselves, and this is one that can penetrate the skin. So tissue migration. In orangutans, for example, the strongyloides Foodborne and Stercoralis are both associated with fatal infections through the tissue migration phases. So folks will prophylactically deworm their apes to prevent those deaths. One of the leading causes of death in our captive orangutans, actually. And they see that in the wild as well in Indonesia. Oxyurids, several different species there. Again, generally a cecum and colon inhabitant. Trichuris, we see some other Trichuris as well, but the Trichuris trichiura is the one that would be zoonotic. There's another one that we've described in our colobus monkeys that actually lives in their stomach. They're leaf-eating monkeys, so their stomach is kind of like a big fermentation chamber, more like a rumen in a cow. And when you look at the pH and everything else of that, it's more like a colon environment than it is a true stomach environment. So they've got their own species of Trichuris that kind of lives there in their stomach as a commensal. It's found in the wild as well. Sophagostomum causes mineralized granulomas in the intestine. Some of the macaques and things like that will get those. Gonjolanema is a spiroid nematode that'll live on the tongue and oral mucosa of some of our New World primates because they like to eat cockroaches, and that's the intermediate host. So, like I said, you can preach to these primates all about hygiene, but they just, that's the one thing we can't control. We see an amoeba histolytica in these guys causing an colitis. We see a lot of normal commensal protozoa as well. So, unlike for some of our other veterinary species, our technicians have to be adept at being able to identify some of these normal commensals and be able to separate those out, which can be a challenge. Balantidium, this is Dumati, our little baby orang that was born quite a few years ago, but here locally. So he's doing really well in Zoo Atlanta if anyone's wondering about him. But orangs and gorillas both are known to harbor Balantidium subclinically. Ours are no different. Generally is non-pathogenic in these guys unless they become stressed or immunocompromised for other reasons. We generally treat them with Humantin or paramomycin for that. Mentioned Giardia earlier. It's a disease that we see frequently enough. Causes clinical signs sometimes, the exception being those lemurs I was telling you about earlier that seem to be subclinical and chronically infected, and doesn't seem to respond to our typical treatments. So if anyone's interested in doing more research on that, let me know. Toxoplasma, of course, associated with cats. Again, the primates eat whatever they can get their hands on. We do see it generally with lemurs. Lemurs are generally from Madagascar, so there's no native felid species in Madagascar. So species that evolved in areas away from cats, we find are really highly susceptible to toxo, and they'll get systemic hepatitis, respiratory disease, and encephalitis from exposure to just a very few ova. So lemurs from Madagascar is one of that. We see animals from Australia, macropods, kangaroos, and wallabies, and things like that are also pretty sensitive to this. But no cats on those two islands. So, Echinoculi encephalozoan is more of a rabbit issue. That very common parasite. How many people have heard of Echinoculi? Is that something that's in the human side at all? Very, very common disease in rabbits, and it is a known zoonotic pathogen for immunocompromised people. We get concerned about it because we use bunnies as outreach animals in hospitals and nursing homes and preschools and things like that. So we screen for this very heavily. There's a serologic test. But New World primates are also susceptible. It causes similar signs to toxo. But I'd say the majority of bunnies that we test are positive for it. We get most of our rabbits for contact animals from our animal care and control, so we know that it's out there in the community, but definitely more of an issue for immunocompromised people. Immunocompetent people are generally not going to have any problems with this particular parasite, but it is one that does cross over. So that's a primate medicine in a nutshell. Questions? Yes.
Late, but we're going to end today with a semi-annual update of TB and communicable disease from our Communicable Disease Division Director, Nikki, and her staff, Nikki Hartman, and her staff, Laura Brown Weaver, or Weaver Brown, and Steve Williams.
Hello again, I'm Nikki Hartman, Director of the Community Health and Case Management. So we do follow up on our communicable diseases in Allen County and active TB case management. I'm going to go through this kind of quickly. We haven't had an update for a while, so I kind of did a recap of numbers from 2011, 12, and the first part of 13 now. Just kind of a slide showing all the different diseases that we follow up on. I think there's 72 reportable diseases, 73 including outbreaks. So even though norovirus isn't reportable to us, if you have an outbreak, it is reportable to follow up on. I just like to reiterate this every time. Diseases are reportable. They're not just reportable by the labs that automatically fax to us, but they're reportable by the physicians that diagnose them and by hospitals. There's different time frames for reporting: immediately, 24 hours, and 72 hours. Here's some of our immediately reportable diseases. One that's not on here, if anybody's involved in our smallpox vaccination training, that's one also. If you are not aware of that, contact me or Candy Stat and we'll let you know about that. We also have reportable within 24 hours. There's one, animal bites to humans. Those are to be reported to the local health department or animal care and control, who will then notify us, but within 24 hours of it happening. Whether it's from their doctor who they go in to get treatment from, their doctor should fill out a bite report and fax it to us, or if they just go to animal care and control, the hospital, whatever, and then we follow up on those if needed. One of the big things is bat proximity exposures, or waking up to a bat in your bedroom. You may need some test that bat for rabies if possible, or get some rabies prophylaxis. There's also reportable within 72 hours. Notice TB's on there, our favorite. And then here is a comparison of 2011 and 2012 disease numbers from some of the top numbers that we have, most prevalent diseases. Of course, hepatitis C is always up there at the top every year, around 300 every year that we don't necessarily speak to all those people, but we do try to follow up with education, make sure that they know that they can get vaccines for hepatitis A and B at the health department. You'll notice E. coli, I'll talk about that later. We had a big surge in that in 2012. So I'll go through each of these real quick. On the right-hand side will be the numbers to compare for each year, so you can kind of get an idea. Hepatitis C is the most chronic bloodborne infection in the U.S., most prevalent among the baby boomers, and the CDC has now recommended that all baby boomers be tested for hepatitis C. It's usually asymptomatic, you don't know till way down the road when you may start to have some symptoms, and there is some pretty good treatment out there now. So, hepatitis B, 800,000 to 1.5 million people in the U.S. have chronic Hep B, but 350 million people worldwide, spread through blood and bodily fluids. Big thing with this, it is preventable. Be vaccinated. Campylobacter is another one that we deal with. It's one of the most common causes of diarrheal illness. Undercooked food, poultry, raw milk. Ann looks into that quite often. Raw milk's being sold as pet food, but people think it's healthier than pasteurized milk, so don't drink that. Prevention, wash hands, clean your food prep areas, and don't mix raw and cooked foods. Streptococcus pneumonia, pneumococcal disease. There's many types of, that disease causes many types of infections, but from our standpoint, for surveillance, we only worry about invasive disease in a otherwise sterile place in your body. So this goes through some of the things: bacteremia, meningitis, ear infections, big cause of that. There are vaccines for this too. Vaccinate, vaccinate. Strep group B, we deal a lot with this. I think this is one they might be deleting from the communicable disease rule. But sepsis, pneumonia, a lot of bone and joint infections. Giardia, one of the most recognized common sources of waterborne disease right now. Fecal oral, yum. People can carry it in their bodies for weeks or months without having any symptoms and infect others. Wash hands, biggest thing. Salmonella, also fecal oral, raw undercooked foods, raw dairy products again, fruits and veggies. Excuse me. Approximately 42,000 cases each year, but as Ann stated earlier, it's probably 29 times that, actually. Again, prevention. Separate your foods, good food safety, and wash your hands. Salmonella has quite a few subspecies and serotypes. Over 2,000 serotypes. It's very complicated. I've done a lot of research on this, and I still don't understand it. This goes through to explain some of the most common ones. Enteritidis, typhimurium, and Newport. We do try to, part of our investigation, figure out what serotype it is and put that in the investigation if we have it. As you see, typhimurium has been the most common, and it is resistant to at least 5 microbials. And Newport is the third most common, and there's a lot of resistance with it too. This kind of breaks down 2012. We had 43 cases, so I kind of went through and showed the age range for those, 4 months to 88 months. I know we looked into all these cases. We couldn't find any kind of common source or anything. And shows it's pretty even distribution of ages there. Went through and did all the different serotypes to kind of see where we stood, and enteritidis, those colors are hard to see, is right up there. The I4,5 found out if they can't identify all the antigens in the salmonella, they give it a number. So it's probably a subtype of the typhimurium. Cryptosporidium, another fecal oral. Most common source of outbreaks in water parks, pools, lakes. It's resistant to chlorine also. So that's a big water safety when you're taking your kids to the pool or with other people and they have their dirty diapers on and that kind of stuff. That's how those things can get spread. We had 18 cases, 2 to 89 years old, a little breakdown there. 41 to 60, it looks like, had the biggest numbers. And then Shigella, another immediately reportable, found mainly in humans. It's very easily passed from human to human. It takes a very, very small amount to infect someone else. Again, 14,000 cases per year in the U.S., but it's estimated to be 20 times greater. As Dr. McMahon had said earlier, a lot of physicians may not think there's really a need for stool testing because they're going to treat the same way, but for surveillance purposes, it's very important. 3 to 79 years, and there's a breakdown in ages again. And then E. coli, that was one that we had an outbreak of last year. Another fecal oral. There's 100 strains of E. coli, but most are harmless. But then there are the 0157s that do cause severe illness in humans, and they are contagious. You can get it through contaminated food, drinking water, recreational water again, unpasteurized milk again. Antibiotics should not be given to people with E. coli. It can cause hemolytic uremic syndrome. So it's not recommended to treat with antibiotics. 2012, we did have 33 cases. Ends up it involved a local school. We were notified. This local school also had people from multiple counties in Indiana and from Ohio. They attended a field trip, 109 attendees, 104 of those were interviewed. 55 reported diarrhea and cramps, 49 did not have any symptoms or meet case definition. And luckily, only one person became ill with HUS, and she was treated with antibiotics. So of the 55 ill, 49 were teenagers at the school, 6 adults, 24 male, 31 female, 22 consulted their own health provider. The rest came through us, and we did testing for them. They ended up with 14 confirmed cases, and there's the case definition, and 41 probable cases. Thank you. This shows a graph of onset date. Symptoms often begin 3 to 4 days with a range of 2 to 10 days after exposure, and they last around 5 to 10 days. Because of the onset date and the date of the field trip, we thought maybe there was something else before, so we went through a whole questionnaire with all the students, but then after that, when we kind of looked at more at the data, then we did a survey monkey with them also, hoping maybe we could get some information that they wouldn't want to give face-to-face to us. But we didn't really find out anything. Then we went through and here's all the symptoms we asked about, number reporting and percent reported. So we had a lot of diarrhea, cramps were big, and blood in the stool. So when we were notified of this situation, we automatically notified the State Department of Health. The investigation involved a local restaurant here in Allen County, as well as a restaurant in Chicago. So the Illinois Department of Public Health and the Chicago Department of Public Health were contacted, and they did their own surveillance and investigations in their areas. As I said, we used a standardized questionnaire that revealed some foods that were common and could be significant. So we went on from there. There was also a homecoming event that was held So not only did that add some other foods to the mix, but also some other people that we had to look into. But no other cases were found from that event. So Ann's division completed the environmental inspections at the school as well as the local restaurants. Everyone submitted stool samples, and we ruled out both of those locations. And then there were no other really red flags at any of the locations either, to give us an idea of what it could possibly be. So we had the laboratory results. 14 cases tested positive for E. coli 0157H7. They do a pulse field gel electrophoresis. It's kind of a fingerprint, and there were 8 different patterns. So the first thought was, well, we have multiple contaminants here. We need to be looking at some different things. They went on to do this MLVA test, and the pattern ended up being identical. So everyone was infected from the same thing, but the strain kind of changed a little bit. So the conclusion, we knew it was E. coli 0157. We still have no idea where they were infected, how they were infected. Was it foodborne? We're pretty sure. There's no suspect index case to really look at that started it all, to know if it was maybe one person who then infected everybody else. You know, it is a field trip to Chicago, a bus, one little bathroom, but that didn't really make sense either. So we still have no idea what caused that outbreak. And then I'll just give you a little bit of numbers of West Nile virus. 2012, we had our highest year since 2002, I believe, 3. Transmitted by mosquitoes. Most people are symptomatic, but 1 in 5 will develop fever. Less than 1% go on to develop encephalitis or meningitis. Biggest prevention here, wear insect repellent. So we had the highest number of cases in Allen County since 2002, where there were 69. The 2012 season began earlier. It was a drought, very, very hot. We had our first human case reported in August, and this shows you kind of when we received most of our cases for the year. 10 of those cases were hospitalized, so we had a more severe, our cases were sicker than usual also. 10 were hospitalized, 5 of them had neurological involvement, and 2 died. This kind of shows you a breakdown of the ages. Most of the cases were between 41 and 60 years, and most were male. Most were female, excuse me. Took this from our Vector Division's report, and it shows all the sample test results. The blue positives are, the blue plus sign is positive, the red is negative. So it's kind of interesting. So from all the communicable disease that we talked about, the key points, as I've said with most of these prevention, you can prevent the spread of a lot of these diseases by washing your hands, by following good food safety practices, getting vaccinations, and using insect repellents. All are reportable to the local health department, and all of them, you need to make sure that the proper testing is ordered so that we can follow up on these and see if there are any kind of trends happening. I'm going to go through this real quick with just some basic numbers, and then Steve and Laura are going to come up and talk about sputum collection and some case studies. So everyone knows TB, bacteria, spread airborne, not contact, can affect every part of your body. And it's very slow growing, which makes testing and confirming TB very difficult. There's different TB infection, positive skin test, or possibly. It's not infectious, may have a normal chest x-ray, no symptoms. I am going to say it is reportable. It will be very soon reportable to the local health department, so I'd like us all to get in the practice of doing that now. TB disease, you're active, you're infectious, you're sick, abnormal chest x-ray, may have a positive skin test, may not. Sometimes they're too sick to actually mount a response to that test, so it will not be positive. For us to diagnose TB, abnormal chest x-ray helps. Biggest thing, sputum testing. We've ran into a lot of issues recently with getting sputums tested and ordered and the exact kind of testing we need to diagnose people quickly. Big thing we're really pushing right now is if you have a positive smear, even right away when you order, add a PCR. That helps us differentiate between regular TB, Mycobacterium tuberculosis, and an atypical Mycobacterium. So we know if we need to proceed on our end or not. And then sometimes we have clinical cases that really are different and the doctor decides, yeah, it's TB, the medicine's helping, but they don't really have any of the normal signs, symptoms, or diagnosis testing of others. In 2011, Indiana had 100 cases. Allen County only had 4, but we had our first MDR case, multi-drug resistant case. 25% of our 4 cases were pulmonary, 75% were extrapulmonary. 75% of the cases were foreign-born. And on my slides for this, I have white, black, and Asian. I didn't use African American because not all are African, not all are African American, but all are black. So, 2012, we had 102 cases in Indiana. Allen County had 16. 56% were pulmonary, 44% extrapulmonary, and white was a big part of that. We had an outbreak. And a healthcare worker. So that's why we encourage everyone who has latent TB, especially healthcare workers, to get treated for latent TB, so you do not break down and have active TB and infect your patients or coworkers. 44% of those were foreign-born for 2012. 2013, so far we have 5 cases, 80% are pulmonary, and most of them are Asian, and 80% are foreign-born. Okay, I want to let Laura and Steve want to talk about sputum collection.
And infectious disease. We're going to go through a couple case studies, and then Laura's going to talk about sputum collection, reasons why, and when, and how to report. I do want to say up front that if I knew that cute or disturbing pictures of primates were allowed, I could have gotten some shots from the clinic and included them in my presentation today. Case study number 1. 46-year-old male, history of HIV positive since 2001. At the time that we interviewed the gentleman, was in full-blown AIDS, unilateral renal failure, was a paraplegic, following a CVA stroke in 2007, and the patient was homeless. He presents with shortness of breath beginning in June, non-productive cough, weight loss of 20 pounds, and loss of appetite prior to June. Chest x-ray showed a left upper lobe cavitation. A chest CT was performed to the BAL at the same time. T-spot was ordered. A CT-guided biopsy was performed with an AFB smear culture and PCR to be completed on the sample of the tissue, but then there were some issues about sample size and compatibility with the lab that the tissue sample was sent to. All testing was negative. This gentleman spent 12 days in the hospital, homeless, self-pay, negative airflow isolation, and if we would have gotten the PCR testing done with tissue samples immediately upon the rule-out attempts on TB, cost of service could have been way down. Case study number 2, 66-year-old male with a history of hypertension, diabetes, chronic back pain, esophageal strictures, alcohol use, abuse, smoker. He presents to the ER with abdominal pain and malnutrition. Over the past 6 months, he's been struggling with dysphagia and a weight loss of 22 pounds in the previous 4 months to that. A PEG tube was placed, and with an overnight stay for observation just to see how he'd tolerate the procedure. Chest x-ray shows a ring light appearing lesion in the right mid-lung, AP view, but does not appear cavitary on the lateral view. IDs consulted. CT then reveals a right upper lobe cavitation. TST placed and bronch performed, in for GI issues, and he ends up AFB smear positive and TST reading of 20 millimeters. Infectious, treated. And this was done within just 3 days. Much quicker diagnosis for this gentleman. And it came in for what would be not considered primarily a TB rule-out case. DOH was consulted and a 4-drug regimen was started. Case study number 3, 48-year-old male is a refugee from Burma, non-smoker, presents with a 6-week weight loss, denies night sweats or cough, does complain of a little neck tenderness with a mass on his right side without drainage. Previous hospital performed a fine needle aspiration in order to rule out cancer, of what they thought might be the biggest concern. Chest CT did show some bilateral nodules on the radiography. Necrotic tissue was seen in the neck mass, and the concern still persisted with a possible metastatic neoplasm. Tissue sample was sent, and an AFB smear was done. Fluid mass was positive for AFB. Pulmonary TB, X-ray, negative. Extrapulmonary TB, the neck mass was positive for tuberculosis, not infectious case, and being clinically treated. So the takeaway from this is that we just don't know who they are. So we have to keep it not necessarily top of mind, but it has to be in our mind that we're thinking about TB, and all it is getting that sputum sample done, getting it sent to the lab, both with the smear for the type of bacterium and then the PCR for the identification of the correct bacterium. And then treatment, isolation, contact investigation can begin immediately. And now I'll turn it over to Laura.
And I will talk more about the sputum collection and how to order and what tests to order, what we use, what we need for our cases and suspects. First off, a sample can be collected anywhere from 8 to 24 hours. We use a lot 8 hours apart because we're trying to rule these people out as non-infectious to get them out of isolation and back to their normal routines and their daily lives. So an example, they could be 10 p.m., 6 a.m., and 2 p.m., and they're still within our guidelines, and those are still valid test results and help us get these people back to normal. However, one sample needs to be early morning sample, first thing when they wake up. Overnight, while people sleep, the bacteria can pool, gives the bacteria a chance to grow more, and it's a little bit more reliable, can really show us if there are bacteria there or if they've been killed off with the medications. And also, the sample size really needs to be 5 mils or more, just depending on what testing needs to be done, how much testing needs to be done. Sometimes they need a little bit more of a sample. The test to order. First would be the AFB smear and culture. We say times 3 because for our purposes we need 3 consecutive in a week because we're ruling in, ruling out infectiousness. The smear result we can usually have back within about 24 hours. The culture can take up to 6 weeks to finalize, and that's usually if they're negative. They'll let it grow for 6 weeks before they determine that it's not going to grow anything. If a smear is positive, we really need a PCR added right away. That really, like Nikki said, helps us determine what is growing. So the PCR or a DNA probe can either be done. That really gives us in about 48 hours an idea if we are really working with a TB case. And then the susceptibilities are very important. They will show us if the bacteria is resistant to any antibiotics, because we'll have to make some major changes to the drug regimen if it is. Now the ISDH will automatically do all of this testing for us on any sample that's sent. However, they don't want just every sample that they that a hospital gets to go directly to them. They'll do anybody that is insured or anybody that's extremely concerning, a huge risk, then they'll take all those samples. And Steve or I, as nurse case managers with the health department, will help facilitate getting the sample from the facility down to the state lab. So as far as what the results mean, a positive AFB smear will indicate if a mycobacteria is present. TB is one of many mycobacteria, so it will kind of worry more depending on their risks. And then, like I said, the PCR, we can have a pretty definitive result back within about 48 hours if we really need to get these people on TB medications. And then the susceptibilities, they are completed off of a finalized culture, so that's 6 weeks and then usually about another week before the susceptibilities come back. And we'll already have those patients on the first-line drug regimen, a 4-drug RIPE regimen, and then from there, depending on the susceptibilities, we'll start switching them over to some of the second-line, third-line drugs. And this is important because the earlier the testing is performed, the sooner we can get those patients on medication. And like I said, we can have a diagnosis in about 48 hours if this person is TB. And this is really important because if they are infectious, we need them in isolation, and we really need to start a contact investigation, especially if there's little children involved. They can have just very aggressively break down to active disease quickly, and it can be very severe. And then treatment is extremely long. In a good case, 6 to 9 months, sometimes a year, 2 years, depending on the bacteria. It takes a long time for the patients to start feeling better, so the sooner we can get them on treatment, the sooner they start feeling better. So the key points is to always consider TB. It may not look like TB. It may be a completely different site where people are coming in with complaints and they can end up with TB. And PCR is extremely important to help get these people in and out and treated appropriately, and we can get involved and get started with our end of it. And to let us know anytime that there's any kind of suspicion, a rule in, rule out patient, we can really help facilitate all the testing and what needs to be done. Is there any questions? Okay.
Well, thanks everybody for staying. I know it's been a long morning. I hope you found it interesting. The rest of the session will be directed towards people that are here for our TB instructor update. Jan, you want to come up here?